Hi guys. So now we're going to be starting with pediatrics. I feel this is one of the subjects which is very scoring. You do get questions, which are just systemic and our integrated systems will incorporate those concepts. Apart from that, essentially neonatology is the one thing where you get maximum questions which is specific to the subject and growth and development. So these are, three topics, neonatal, growth, development that you particularly need to focus on. And then there are a few niche topics like cystic fibrosis, congenital heart disease, CH, that we shall be talking about. So let's begin with neonatal. So the first half of this video is going to be about neonatal and then the rest of it, okay? So few definitions here. What do we call as a low birth weight? So anybody who is less than 2.5 kg is low birth weight. Very low birth weight is less than 1.5 kgs, whereas extremely low birth weight is less than 1 kg, 1000 grams. So these are on the basis of the weights. But then this is very subjective, right? We need to know with respect to that gestational age. For example, a preterm born is obviously going to be a lower birth weight. So with respect to that gestational age, how is the weight? These three parameters tell us. Okay, so this is very absolute in terms of the weight, but this is incorporating with respect to the gestational age. So what is called as appropriate for gestational age is anybody who corresponds to 10th to 90th centile, okay, of their weight. So that is what you need to remember, that in that gestational age, they correspond to the 10th or 90th centile. If somebody is less than 10th centile, that is called small for gestational age. And if somebody is more than 90th centile, that is large for gestational age. In large for gestational age, you need to know a few causes. Obviously, the most important one is going to be infant of diabetic mother, right? You know that they have macrosomia. So one of the most important causes and one of the most common causes of a large for gestational age or a macrosomic baby is going to be infant of diabetic mother. Apart from this, you want to remember Sotos syndrome. This is one congenital syndrome where babies are large for gestational age. And another thing which is expected is actually Beckwith-Wiedemann. So you want to remember Beckwith-Wiedemann syndrome will also be large for gestational age, and we shall be talking about other features in the latter part where we talk about genetic disorders where these babies will have macroglossia, they will have a protruding tongue, they can have an umbilical hernia, higher risk of Wilms tumor, and they have this characteristic ear double crease that I'm going to show you. So we'll discuss more about it then, but remember as of now these three differentials for large for gestational age. Small for gestational age, on the other hand, you need to know how to distinguish it from IUGR. They are not the same. IUGR, as the word says, is intrauterine growth restriction. So this is where a baby is going to have less than 10th centile weight, which is the fetal weight, plus abnormal Doppler indices. So IUGR essentially is an ultrasound diagnosis. It's where you also have to see the Doppler parameters that I'll teach you in obs and gynae. We talk about abnormal umbilical artery Doppler. We'll talk about abnormal middle cerebral artery Doppler. So that is what you need to see here, abnormal Doppler. So that's IUGR. IUGR further can be divided into two. It can be symmetrical or asymmetrical. The causes of symmetrical IUGR will include either congenital infections like TORCH or any congenital anomaly, whereas asymmetrical is essentially because of uteroplacental insufficiency. This is where we are talking about, the abnormal Doppler indices, etc. When we say that, we essentially mean asymmetrical IUGR, which is because of a uteroplacental insufficiency. How to diagnose this is on the basis of head circumference. Remember, both will have reduced abdominal circumference, right? So the abdominal circumference is reduced in both of them. What you have to remember, it's the head circumference which will be the difference. So you see this characteristic brain sparing effect in asymmetrical IUGR. So when our body is in crisis, there is no blood flowing, you know what the baby decides? The baby decides it's my brain which is going to save me later. So the body now shunts the blood into the brain, and you're going to see paradoxically increased blood flow. So that's what we are going to learn, that the middle cerebral artery flow increases actually as you have IUGR. So that's what I'm going to teach you later on when we go to IUGR per se in obs gynae. But as of now, you want to remember that here the head circumference is normal, whereas in symmetrical, even that is going down. So that's why can you understand that this is intrinsically a poor prognosis, whereas asymmetrical is going to be a good prognosis. When we talk about ponderal index, you want to remember this is gram per centimeter cube, meaning the estimated fetal weight upon the fetal length cubed is what is the ponderal index. It is normal in symmetrical. Okay? You want to remember that it is more than 2. More than 2 is normal. Okay, so this is what it is in symmetrical, whereas it is less than 2 in asymmetrical, right? So this is something which is very, very important. Now let's talk about a few other things. So there is physiological weight loss that happens in every newborn. Okay, so 2 numbers you want to remember. In a term baby, you want to remember that they lose up to 10% of their body weight and they recover it by day 10. So in the first 10 days of their life, their weight is gonna undergo a drop actually. Rather than gaining weight, a newborn baby is gonna lose up to 10% of their birth weight, and then it dips at around 3 to 4 days and then it recovers slowly, and by the time the baby is around day 10, they reach their birth weight and then the gain actually begins. So you want to remember 10% regained by day 10. On the other hand, in a preterm, the weight loss is higher. The physiological weight loss here, remember 15 and 15. They lose up to 15% of their weight and they are back to their birth weight by day 15. So this is not something which is abnormal. This is physiological is what you want to remember. Doesn't indicate that the baby is not feeding enough. That's the mistake students make, that in the first week if a baby is not gaining weight, they say that the feeding is inadequate. No, this is physiological weight loss, nothing to do with feeding, right? So that's what you need to keep in mind. After this, if they don't gain, then it might be a reflection of lack of feeding. Okay. As far as most common cause of mortality is concerned, so these are values from pediatric data. There might be a little discrepancy, this is a little controversial, where PSM data and PEDS data are a little conflicting, but this is what I am telling you. You can follow this, but if you have any other reference, you can share as well. So most common cause of mortality in a neonate versus under 5. In a neonatal mortality, prematurity is the most common cause, followed by birth asphyxia, followed by sepsis, followed by congenital anomaly. So you can remember PAS-C. Okay, PAS. We remember PAS staining, remember PAS. In under 5, you have pneumonia, which basically infections, right? So pneumonia followed by diarrhea, followed by injuries and malaria. So this is for under 5. So this is what you need to remember about a few basic points. What is expanded new Ballard score? A question hasn't been asked from this, but I expect that it can be tested. So this is a combination of testing the neuromuscular maturity and physical maturity in a baby to see the gestational age, right? So these are parameters which tell you about the gestational age. We can talk about a gestational age right from 20 weeks till 44 weeks. So we can comment upon the gestational age on the basis of the score that you get. So the POG that this can give us is from 20 to 44 weeks. They will not ask you to obviously tell the score, but you just need to know a few general points, and it will also tell you how a preterm baby looks and how a post-term baby looks and what is normal. So if you just see these, if you just read these words, you'll get a reflection of what a preterm looks like and what a post-term looks like. So in the beginning, you can see all of these are preterm points. So essentially, except for lanugo, you want to remember that everything is becoming more and more pronounced as the baby grows older. So skin was transparent, translucent, then becomes normal, and then it becomes very thick and leathery. Lanugo is the only one where things are different, where lanugo abundant is what is a term baby. In a very preterm, you will not have lanugo. In a very postterm baby, you will not have lanugo. So this is the only exception. Everything else, you will just see that it keeps increasing. Plantar surface, the creases increase. Breast from imperceptible becomes a full areola and 5 to 10 mm bud. Eyes and ears, here the lids are fused, then slowly they start to open and the ear cartilage becomes stiffer. Genitals, male and female, from empty scrotum, now the testis descends down and the testis is more pendulous with deep rugae, whereas in female, from a small clitoris and small labia, you have bigger size of the genitals. So that is what is happening in physical maturity. Very logical, except lanugo, it's all very instinctive. Then you talk about neuromuscular maturity. In neuromuscular maturity, look at this. First, the posture. So you can see as the baby grows older, there's more and more flexion now, right? So you are seeing from an extended posture, there is more flexed posture. Then you have square window, which I feel has been asked. So again, as the baby matures, the flexion ability increases. That's what we saw on the top. That's what we see here, that from a 90-degree angle, now the flexion is happening and you can have as much as 0-degree flexion. The flexion at the wrist, okay? So this can be tested. Arm recoil, you are seeing that previously there's no recoil, but now you can see less than 90 degrees. So again, essentially the flexibility, flexing increases. We flex more when we grow up, right? So happening with this baby also. Baby is flexing more and more as the baby grows older. Then popliteal angle is a little exception here, where you see that when you are bending this baby, this is 180, but this keeps decreasing, okay? So the popliteal angle is thoda opposite. Scarf sign, again a little opposite here. So scarf sign is this: when you take your elbow to the other side, this preterm baby can, and as the baby becomes term, now it's on the side, okay? So this is scarf sign. And heel to ear also, you can see first the baby is extremely flexible and then you can't take it. So the last three are opposite of increased flexion, whereas first three tell increased flexion as the baby grows older. So that's how you're going to remember that posture, square window and arm recoil. These are what are things which are going to be decreasing, whereas popliteal angle, scarf sign, heel to ear are essentially more in a preterm and decrease as the baby grows older. Right, so this I don't know how they'll ask you this, but you just want to know about this. All of these things like square window, arm recoil, scarf sign does seem important, okay? So this is what is the expanded new Ballard score. Now, a few benign newborn lesions that you want to know about. So, essentially, you need to know that these are not something to be worried about. They are going to resolve on their own. So, all you have to remember is you reassure the parent when you see them and you give them a diagnosis. So, what is this? This is where you will see this red lesion here. This is what is called as erythema toxicum. The name itself sounds very toxic and scary. So, if you tell your parent that your child has erythema toxicum, it's nothing, it's benign. Okay, so they've named it how it's not very, very benign sounding, but it is a benign lesion. E for erythema, E for eosinophils. Okay, so you want to remember that if you do an aspirate, you're going to see eosinophils. This is a benign lesion, will go away. On the other hand, this pustular sort of a lesion, so this is also benign pustular dermatosis, right? So pustular dermatosis of a newborn. Here pus meaning neutrophil. So this is where you are going to see neutrophils if you do an aspiration. You can see these milia here. These are nothing but the miliaria. Remember the miliaria version I taught you in dermat? This is the pediatric version of that. So smaller name. This is milia, which is nothing but the obstruction of the sweat glands, right? So obstruction of the sweat glands, the eccrine sweat glands, which are going to be these crystalline lesions. This is called as milia. Then look at this, half baby is, completely pink, half is not pink. So this is what is pretty scary. This is called as a harlequin change and essentially represents some sort of a vascular phenomenon which is normal. You can also see this capillary network. This is cutis marmorata. Again, normal only. It's just that the skin of these newborn babies is very translucent, so you can see through, and that's why you just reassure it's going to be okay. So this is cutis marmorata, but this should remind you of something. This should remind you of livedo reticularis that we see in adults, right? Do you remember? We see this as a side effect of amantadine. Okay, so this is the pediatric version. This is not the same thing. I'm just trying to correlate this lacy reticular pattern here. This is cutis marmorata. This we have seen in dermat as well. What is it? It's dermal or epidermal. This is dermal pigmentation that you see. These are Mongolian spots that are seen in the buttocks. That represents dermal pigmentation. That's why it is blue to slate gray. Usually goes away in 2.5 years. What you see here is a capillary hemangioma. This is what is called as a strawberry hemangioma or a stork bite. Okay, so this is what is also referred to as a stork bite. this usually regresses. If it's in a newborn, it usually regresses in a couple of years, okay? Even if it doesn't regress, it doesn't enlarge. So that's what you want to remember, that this may regress. So this is actually representing a capillary hemangioma. Okay. Then a neonate may have acne, and this could be an effect of maternal transfer of a few androgens, so they can develop acne. If there is maternal transfer of estrogen in a female child, they may have presence of breast enlargement. So they may have this breast enlargement, which is called as mastitis neonatorum. Okay, so this is something which is benign. And they may also have vaginal bleed. Okay, so they may also have milk getting expressed from the breast, or they may also have vaginal bleed. So both of these things you want to remember are because of the maternal passage of the estrogen, and it's benign finding, it's gonna go away. Fine. And what is this? This is a cradle cap, pretty common. This is seborrheic dermatitis that newborn babies have. Right? So cradle cap, seborrheic dermatitis, just reassure, it'll go away. But one thing should be kept in mind, that this, if along with other findings, seborrheic dermatitis or cradle cap is also something that you see in LCH, right? So just remember this, not in a newborn, but in a child, if you have characteristic polyuria, polydipsia complex, you are having this scalp lesion, bony lesions, then do think of, seborrheic dermatitis or cradle cap as one of the cutaneous manifestations for the same, right? So this is seborrheic dermatitis. Now talking about extremely important neonatal hypothermia. Now neonates have a very, very close range of normal temperature. All four of these numbers you got to remember. So look at the normal range. It's 1 degree. It's 36.5 to 37.5 degrees Celsius, which is normal. 0.5 degrees Celsius is a buffer that you have, which we call as cold stress, where the extremities are cold but the body temperature is still maintained. So that's cold stress. And moderate hypothermia is 32 to 36, and less than 32 is severe. So you need to remember this range here. How we measure the temperature of a baby is axillary temperature, and ideally you should measure it for at least 3 minutes. Okay, so that's the most common site of measuring a neonate's temperature. Now, how does a neonate maintain their body temperature? If it is cold, do they have shivering mechanism? They don't. We have studied this in biochemistry, that they rely on non-shivering thermogenesis, which is because of the presence of brown fat, right? Do you remember the uncoupler box we had done? So they rely on non-shivering thermogenesis, and this is because of the presence of brown fat. Okay, so brown fat is basically an uncoupler, and that is what causes this non-shivering thermogenesis, and it's present usually around the axilla, around the scapula, nape of the neck. So look at this image. First of all, what is this investigation? You can see that the bone here is white, and you see these hot spots. This is a PET CT. So what are these hot spots that you are seeing? Are they tumor? They're not tumor. These are areas of brown fat that you can actually see. So if you actually do a PET scan, the retained areas of brown fat, even in an adult, sometimes it's retained. Even in an adult, sometimes it's retained, right? So that's what you can see on a PET CT. So the frequent signs, will be bilaterally symmetrical around the scapula, around the axilla. When you see this, this is what is actually representing physiological uptake on a PET CT of brown fat. Just going on to show how metabolically active it is, right? Because it is so metabolically active, you see physiological PET uptake, right? So this is what you need to know about brown fat and its location. So you want to remember, it is around the axilla and around the shoulder and neck. Okay, very, very important, kangaroo mother care. So now in India, there are so many babies, who will need some sort of external heating. But we don't have as many NICUs to support them, but we do have mothers. So this is where you use the mother's own heat to support the baby, and this is kangaroo mother care. Kangaroo mother care can be essentially done in any baby, right? So any child can have kangaroo mother care. It's just that they say that anybody who is less than 1800 grams is gonna need specialized care. So less than 1800 gram, you must definitely refer, and kangaroo mother care is not something which should be done for these babies. They are too, sick or too small to be doing this. So kangaroo mother care, I can say in other words, can be done in any baby who is more than 1800 gram. It can be tried. Okay. So what are the 4 components? So they ask you the components of kangaroo mother care. First is kangaroo position. This is skin to skin contact between the baby and the mother. So you can see how the baby here is not wearing any clothes except for the diaper, and you have the mother's bare chest. So this is where you have skin to skin heat transfer. This is to prevent hypothermia. This is the main mechanism of preventing hypothermia. Kangaroo nutrition refers to the exclusive breastfeeding that is advised, right? So the baby is advised exclusive breastfeeding by the mother. This position also, promotes lactation in a mother, improves the bond between a mother and a baby. So this is exclusive breastfeeding. It's going to prevent, malnutrition. Kangaroo support, you want to support the baby and the mother in the initial phases. The hospital staff will help them. Later on, the family should support the mother and the baby. And kangaroo discharge, we want early discharge from the hospital, because what is the most common cause of neonatal sepsis? It's hospital acquired infections, right? So kangaroo mother care, you are not using anything from the hospital, you are using the mother essentially. So why keep them in the hospital and give them the additional risk? So you are discharging them early. So this is what you want to remember are the 4 components of kangaroo mother care. You get direct questions from this, essentially tackling hypothermia, malnutrition and neonatal sepsis at the same time. So this is kangaroo mother care, 4 components. But if you do need specialized heating, there are 2 mechanisms you need to remember. What is this? This here is an incubator. The main mechanism in incubator, C for incubator, C for convection. Whereas this is what is a radiant warmer. Radiant warmer, as the name suggests, uses radiation as the main mechanism of heating. So incubator, radiant warmer. So this is what you need to remember as far as hypothermia is concerned. Moving on to very important, neonatal jaundice. So neonatal jaundice, what is pathological, what is physiological? Do you want to remember 2 tables? No, just remember pathological. Whatever is not pathological, it's physiological, right? So pathological jaundice, 1, any jaundice in the first 24 hours is always pathological. The most common cause of, jaundice appearing in less than 24 hours is actually ABO, incompatibility. Apart from this, do you remember spherocytes? So we had studied few causes of spherocytes. Most common, I told you, was autoimmune hemolytic anemia, and then you had hereditary spherocytosis and G6PD. Out of this, what will not present at birth? Yes, autoimmune will not present at birth. So remember, this way the other 2 causes will present at birth. So you have hereditary spherocytosis and G6PD. So these are your 3 causes of jaundice in the first 24 hours. Jaundice persisting more than 14 days is what we call as prolonged jaundice. Various causes of prolonged jaundice. This could be because of hypothyroidism. We will study this under breast milk and breastfeeding jaundice. These are usually prolonged jaundice. So you have breast milk as well as breastfeeding. Breastfeeding could be any time, but could be prolonged as well. So predominantly breast milk is prolonged. And cephal hematoma. If a baby has birth injury, cephal hematoma, now this blood is going to get degraded slowly. Excess blood is what is going to result in more bilirubin generation, prolonged jaundice, right? So these are few causes of prolonged jaundice that you want to keep in mind. Then the increase, if any increase more than 5 mg per dl is abnormal, and if the total bilirubin reaches more than 15, that's abnormal. And what's the physical counterpart of that? The Kramer's chart. So there's something called as Kramer's chart where you see this cephalocaudal progression of jaundice. The moment it stains the palms and the soles means it's reached more than 15. So that's a subjective way of saying that it's more than 15 means the palms and soles are stained. Right. So Basically, for neonatal jaundice, you are going to see the baby subjectively, what part is stained, and if you feel that it is more than normal, the first test done is this one. What is this here? So this is what we call as TCB, transcutaneous bilirubin is measured by this. Okay, so this is a non-invasive measure of the jaundice. So you will do this TCB. These also have certain cutoffs. If it goes beyond the cutoff, then you will go and do the serum bilirubin. So this is what is called as TSB, total serum bilirubin. So you will start off with TCB and then you will do TSB if found abnormal. In total serum, now you will see what is direct, what is indirect. That will tell you conjugated or unconjugated. So this is how a jaundice patient is, or a jaundice baby is approached. Okay. So that's the approach I'm going to teach you. So unconjugated or conjugated. Let's talk about unconjugated first. So first two are your congenital hyperbilirubinemia, where you have a problem with the conjugating enzyme. UDP glucuronil transferase. This is the one which is conjugating the bilirubin. If this is severely deficient, this is Crigler-Najjar. And if this is mildly deficient, this is what is Gilbert syndrome. Gilbert syndrome usually will not even present in the neonate. It may occur later on in adult life, where you will just have jaundice, if there is some stress, if somebody has fever, that is the time you will have jaundice. So this is not something we are worried about. So let's talk about Crigler-Najjar. Crigler-Najjar has two types. So you have type 1, where it is absent, the enzyme is not there, and then you have type 2, where it is very, very deficient. Okay, so this is type 1 versus 2. How can I distinguish? Can we use phenobarbital? What is phenobarbital? You remember all anti-epileptic drugs are enzyme inducers except valproate, right? So phenobarbital barbiturate is an enzyme inducer. So when we give phenobarb, this UDP glucuronil transferase will be induced. So what will phenobarb improve? Type 1, type 2, or both? It will only improve what is present, right? If there is no enzyme, what will it induce? So if there is improvement on giving phenobarbital, it's type 2. If there is no improvement on giving phenobarb, it's type 1. That's how we distinguish. Type 1 is the type where you have very high risk of all of this unconjugated bilirubin going into the basal ganglia and depositing there, leading to kernicterus, right? So most of these babies don't survive. They're going to develop this kernicterus, right? So you want to remember type 1 versus type 2. So this is about Crigler-Najjar. Then you have two other causes of unconjugated jaundice. You have breast milk and breastfeeding. Essentially, it's all in the name. If you see the name, you get the answer. So breast milk jaundice, milk is the problem. You have certain compounds in the milk like pregnanediol, which are going to inhibit the same enzyme, UDP glucuronil transferase. Okay, so this is what is going to inhibit, and that's what results in prolonged jaundice. So what do? Do you stop breastfeeding? No, that's going to be even more counterproductive. So we don't want to do that. So you treat these babies with phototherapy and you continue breastfeeding them. Okay, so you continue breastfeeding them. Slowly, the baby, the baby itself is going to learn how to manage this pregnanediol and, deal with it and metabolize it. So this is just a transient problem. So in that time, you will do phototherapy if the jaundice is high enough. Otherwise, don't stop breastfeeding. That is what is very, very important. Whenever somebody will ask you, do you stop breastfeeding? Unless it is galactosemia, always answer that we will not stop, because the benefits are always going to outweigh the risk, except galactosemia. Right? So this is breast milk. Breastfeeding, as the name says, feeding is the problem. So this is where the feeding is inadequate. If the feeding is inadequate, the baby is going to be dehydrated. There is hemo concentration, more hemolysis, more unconjugated hyperbilirubinemia. Right? So how do you treat it? You correct the feeding, whatever is the problem. A lot of times the baby is not latching properly onto the mother. There is improper position and attachment. So if it is there, you will correct it. If the output, milk output is not enough, you will supplement it. If you want to supplement feeding, what is the best supplement? Is it breast milk or is it formula milk? It is always breast milk. Okay, so there are a lot of milk banks now. Okay, in India, this concept is not very prevalent, but at least in metro cities, there are these breast milk banks, okay, where you can have donors who will give breast milk. So, breast milk bank, or basically donated breast milk, is the best supplement. If this is not present, then the second best is formula feeds. Okay, so this is what you want to remember. If the primary mechanism of inadequate feeding can't be corrected. Okay, so this is about unconjugated. When we talk about conjugated, any conjugated hyperbilirubinemia is always abnormal. Definition: direct bilirubin more than 2. So even if your overall cutoff is not met of 15 mg per dl that we studied, if direct is more than 2, it's abnormal. That's what is very important, and you will have clay colored stools here. So what is the problem? 2, congenital hyperbilirubinemia. So here you will remember Dubin-Johnson and Rotor syndrome. So you have Dubin-Johnson and Rotor. Dubin-Johnson is where this MRP2 channel is not working. Do you remember we studied this in Verapamil, where I said ATP binding cassette? This is that ATP binding cassette which is responsible for efflux of drugs. It's the same thing which is responsible for efflux of conjugated bilirubin from the hepatocytes. So if this doesn't work, now all of this conjugated bilirubin is going to accumulate. It's not going to be released from the hepatocytes. Similar problem in Rotor as well. How we distinguish them is on the basis of a black liver. Black liver is because of epinephrine metabolites. Remember that it is because of the presence of epinephrine metabolites. So it is not because of bilirubin. So this is something which is a very commonly asked question. So black liver, Dubin-Johnson; no black liver, Rotor. If you want a little racist mnemonic to remember, you know DJ Bravo, right? So he is a black person. Yeah, sorry for the racist mnemonic, but I'm just making an observation so that you remember better. Okay, so this is DJ Black. That's how you'll remember it. Next, very important, last to last year NEET question, they had asked you conjugated hyperbilirubinemia with periductal fibrosis. So when they use this term periductal fibrosis proliferation, this is EHBA. What is EHBA? Extrahepatic biliary atresia. So this is where the bile ducts are not canalized. This is where they are fibrosed, right? So this is bile ducts being atretic. So extrahepatic biliary atresia is what you have to remember here. So investigations get you a lot of questions. The first investigation, remember, is ultrasound. So what do we see on ultrasound? Do you remember something I had taught you in radiology, that we see portal vein and anterior to portal vein runs the CBD, right? So if you remember, I had shown you one double barrel sign where both were dilated. So that's how we were learning CBD. Here, the bile ducts are all fibrosed. So instead of the black anechoic lumen, what I'm going to see is this fibrosed hyperechoic structure anterior to the portal vein. So we are going to see this sign called as triangular cord sign, where you see this hyperechoic cord-like structure anterior to the portal vein. Okay, so that's what you want to remember, is what we'll see on ultrasound. Apart from this, you also want to remember another sign that you can see, which is called as the ghost gallbladder triad. In this, what you will see is the gallbladder essentially becoming very, very small and atretic. So that is what you want to remember. Nothing about the triad. Just want to remember that the gallbladder is small, because no bile duct only, how will the gallbladder get the bile? So this is where you have a very, very small gallbladder. Okay, so this is what we see on ultrasound. We get preliminary evidence. The one investigation which will get you highest negative predictive value, this is HIDA scan. So what you want to remember is HIDA is not a rule-in investigation. It's a rule-out investigation. Matlab, if I do a HIDA scan, what happens? We'll see the bile ducts, we'll see CBD, we'll see them opening into the small bowel. If you see small bowel opacification, it can't be EHBA. That's what I'm trying to say, that you can rule it out. But if you don't see opacification of small bowel, then it could be anything. It could be EHBA, it could be neonatal hepatitis, it could be these disorders which are not effluxing the bilirubin, right? So that's what you want to remember here, that it's a rule out investigation. So that's how you will answer it, okay? It's neither the best nor the investigation of choice. Only when they ask you what is the best to rule out, then you say HIDA. Okay, that's the meaning of negative predictive value. Gold standard, or if they ask you investigation of choice, this is intraoperative cholangiography. Okay, actually the word has the answer, IOC. Okay, so intraop cholangiography, this is where intraoperatively you will basically puncture the biliary duct and you'll put contrast and you'll see whether it's opacifying the bowel or not. This is the direct evidence that you get. So this is the gold standard, right? So this is what you need to remember about EHBA. But if they tell you, before I go into the next differential, the management, okay, so for EHBA we have something called as the Kasai procedure, that is the treatment of choice, that is nothing but Roux-en-Y hepaticojejunostomy. Wherever you have the canalization, you are going to join that part of the bile radical to the jejunum, right? So that is what you are doing in Kasai procedure, which is essentially a hepaticojejunostomy procedure. But this can only be done within the first 60 days of a baby's life, and if there is no cirrhosis. Unfortunately, most babies, by the time they reach the right treatment facility in India, you know how it is, right? They'll keep referring you to higher centers until, you reach the place where the surgery can be done. It's either the cirrhosis has set in or it's more than 60 days. So in that case, you will now have no other option but to do a liver transplant. And if you remember in surgery, I taught you the most common indication of liver transplant in a baby, in a child, is actually EHBA, right? So that's very important. The other differential, if there is conjugated hyperbilirubinemia but no fibrosis, think of neonatal hepatitis, right? So that's something which is a very close differential of EHBA. So if it is not EHBA, we call it a neonatal hepatitis, right? So this is what is the approach. These two tables will take care of so many questions, okay? Very important. How do we treat jaundice? So this is what is commonly done. I'm sure you would have seen this. This is what is phototherapy. So you can see this blue light. In layman terms, we call it blue light lag raha hai bacche ko. So this is what is phototherapy. In phototherapy, you want to remember there are three mechanisms. The most important mechanism is structural isomerization, where this light is going to convert the bilirubin, which is excess, to lumirubin. So bilirubin is converted to lumirubin, and this lumirubin is what is the water soluble form, right? So this will get excreted in the urine. So this is the main mechanism. Apart from that, there can be photoisomerization, which changes the photoisomer from Z form to E form, and photooxidation can be done, which you can remember is the least important form. So now a few specific numbers here. The distance at which the baby is kept from the light is 45 centimeter. The wavelength is 450 nanometers. So you can remember 45, 45. And the irradiance is 30. So 30 and 30. So 230, 245. This is how you remember the numbers. The type of lamp is an LED lamp. Okay. So this is what we do. So now on the basis of the gestational age and the bilirubin that is found, there are specific charts, right, that we use in order to determine whether phototherapy should be done or exchange transfusion should be done. Now in the exam, if they give you a question on the management, obviously you don't have access to the chart. So that's why I'm showing you this derivative version of the same that you can use for solving MCQs. In practice, this is not what is used. There are specific charts that are used, but for exams, you can remember these values. So depending on the age of the baby, these are the cutoffs for phototherapy: 15, 18, 20 and 20, 25, 25 for exchange transfusion. So one generalization we can make looking at this is any bilirubin more than 25 mg per dl, we have to do exchange transfusion, right? So you can just remember these values: 15, 18, 20 and 20, 25 and 25, right? So these are your management of neonatal jaundice. So now we talk about neonatal sepsis. First of all, a few common causes. So the most common cause of neonatal sepsis, if they just ask you this overall, up till now it was thought it's Klebsiella, but now in a lot of areas, Acinetobacter is becoming the most common cause. Okay, so this is always gonna remain controversial because it's a very geographical concept, right? So most of the time nowadays they don't even ask you these most common questions, but in case they do, you wanna remember Acinetobacter. If it is in the options, becomes a better choice. If not, go for Klebsiella. As far as early onset sepsis is concerned, there is no controversy. So they will ask you this question, don't get it wrong. Early onset neonatal sepsis is group B strep, right? So group B strep, you know, is S. galacti, which we have seen is present. If it is acquired from the vaginal canal while giving birth, right? So that's why it presents early. So early onset group B strep, you remember B for babies, camp test, right? So it's the same group B strep, most common cause of early onset sepsis. Most effective method for prevention of neonatal sepsis is hand washing, right? Effective hand washing, we have learned the Suman K technique, right? In micro. So hand washing should be done for at least 3 minutes, which is adequate, right? So this is where you can prevent most of the hospital acquired infections. The earliest clinical feature of neonatal sepsis will be inadequate feeding. So there will be feeding abnormalities that happens the first. The initial investigation is a sepsis screen. So they can ask you what all are included in the sepsis screen. So there are 5 parameters. One is leukopenia. So instead of increasing, now it's going to decrease in a neonate, right? So there is WBC, total leukocyte less than 5,000, out of which neutropenia, absolute neutrophil is less than 1,800. Immature neutrophil to total neutrophil increases. This is equivalent of the left shift, right? That we saw in appendicitis also. You know the concept that when the demand increases, you're going to have more immature forms, more left shift. Then you have ESR and CRP. So ESR increases, CRP becomes positive. So don't make a mnemonic for this. Essentially, you have TLC, neutropenia, immature, and you have ESR, CRP. Any 2 out of 5 are positive. This is considered to be a positive sepsis screen. The next step that you're going to do is you're going to culture, right? So investigation of choice is culture, but you don't wait for the reports. Now you start empirical antibiotics, right? So broad spectrum antibiotics are given until you have a specific report. Risk factor for neonatal sepsis will be prematurity, preterm, rupture of membrane for more than 18 hours because this predisposes to chorioamnionitis, which predisposes to group B strep, and a positive pressure ventilation. That's also something you can remember. Increases the risk of neonatal sepsis, right? So this is about sepsis. Now very, very important is neonatal respiratory distress. So this is where I'm going to give you buzzwords that you have to identify in the history, the radiological features, and the diagnosis. So we're going to do this pattern approach. That's how you have to learn here. So if they tell you that it's a preterm baby, apart from preterm, you also want to remember infant of diabetic mother inherently has a higher risk of respiratory distress syndrome, right? So even if they may not be preterm, IODMs have a higher risk of developing hyaline membrane disease. So this is HMD, hyaline membrane disease, also called as just respiratory distress syndrome. So this is where you essentially have a preterm baby where the surfactant is deficient. So because there is no surfactant, if you remember from respiratory physiology, surface tension antagonist, when surfactant is not there, the surface tension increases, meaning the lung compliance decreases. Because the compliance decreases, that's why you have no alveolar inflation. The alveoli are all collapsed. Because there is alveolar collapse, now what do you see? You see this diffuse whiteness. So you see this white out lung here. Okay, so you have a white out lung that is present here. The air within the bronchus then shines out because the bronchus are not the problem. It's the alveoli which are collapsed. So you have white out lung. This is what we call as the air bronchogram sign. And overall, how are the lung fields going to be? Underinflated or hyperinflated? Underinflation, right? So they are going to be underinflated lung fields. So these are the radiological features. How do we test for lung maturity? So these are few tests that you can do on the amniotic fluid in order to test for lung maturity. So the first one is lecithin to sphingomyelin ratio. If this is more than 2:1, this is normal. It is the lecithin which is the main component. What is it actually biochemically? This is dipalmitoyl phosphatidylcholine. So, dipalmitoyl phosphatidylcholine is what you want to remember. This is the active component of the surfactant. L to S ratio should be more than 2:1. Nile blue sulfatase test. Now, this is a trick question. If there are fat globules, which are essentially the surfactant, this is what we are testing for. You will have orange cells, right? So, orange cells actually indicate the presence of lung maturity and not blue cells. That's how they usually trap you. They'll give you blue cells. It's orange cells which indicate maturity. And this is what is called as the shake test. Okay. So, this shake test is where you take drop of amniotic fluid and you combine it with 95% ethanol and then you shake. If the surfactant is present, you're going to see this bubbling here. So, this is what is a normal appearance of a mature lung. Important is the treatment now. So, how do you treat respiratory distress syndrome or hyaline membrane disease? So, first step, remember, is positive pressure ventilation, right? You have to give them ventilation. Another technique that you can know about is Ensure. This was tested in one of the INICTs. Ensure is you intubate the child, inject surfactant and extubate. So, this is what is administration of surfactant using intubation. Okay. There is another modification of the Ensure technique now, which is less invasive, and the name is LISA. What is LISA? It is less invasive surfactant administration. Okay. So, you just want to know these acronyms. Ensure, and the modified version or the latest version of Ensure is now LISA. If all fails, the last resort will be to intubate the child and give mechanical ventilation. Okay, so this is what you want to remember for the management. So, first step, positive pressure ventilation, doesn't respond. Ensure, doesn't respond. Intubate and mechanical ventilation, right? So, this is about respiratory distress syndrome. If you have a term baby who's born by LSCS, now normal babies, when they pass through the vaginal canal, they're going to squeeze their chest, right? So, whatever is the water that's going to come out. But here, a baby born by LSCS may not squeeze the lungs enough. So, you will have some fluid accumulating. So, this is what the X-ray is showing. You have fluid accumulation within the fissures, you have fluid in the CP angles. So, this is what you see in transient tachypnea of newborn. So, there will be fluid in fissure or CP angle. So, this is transient tachypnea of newborn. The buzzword here is term LSCS. Okay, so this will resolve on its own. Post-term baby, if they give you a post-term baby, they might mention meconium stained liquor, and look at the X-ray now. You are seeing that there are a lot of these bronchovascular markings. You also see the lungs will be hyperinflated. The surrogate marker to do so is the flattening of the diaphragm. This indicates hyperinflated lung fields because of meconium aspiration syndrome. So, the diagnosis here is meconium aspiration. Remember, any foreign body aspiration, I told you there will be hyperinflation. Here now diffusely the meconium has been aspirated, so diffusely the lung fields become hyper. So, very important, in HMD we learned underinflated lung fields, in MS the lung fields are hyperinflated. Okay, so hyperinflated lung fields and increased bronchovascular markings because of the aspiration is what you want to remember. Next is something we have learned. So, you see the history of scaphoid abdomen. Look at the X-ray. You can see the bowel loops have come into the thorax. What is it? This is congenital diaphragmatic hernia, Bogdalek type. You remember BPL. Bogdalek is posterior defect on the left side. So, what is contraindicated is bag and mask ventilation. Contraindicated. This has been asked a lot of times. You will not resuscitate this baby using bag and mask because that air will further inflate the bowel loops. So, we have done this. The next step is to intubate the baby, protect the airway, and then put an NG tube which will decompress the bowel loops, right? So, this is about congenital diaphragmatic hernia. Next, if you hear the history of sibling death, this is where you have a problem with surfactant protein B. Now, this is not your surfactant. This is what is a protein of macrophage. So, this is what doesn't allow the macrophages to clear the debris from the lung. So, this is where you have the accumulation of substances within the alveoli. This is PAP. What is PAP? This is pulmonary alveolar proteinosis. Okay, so this is PAP, pulmonary alveolar proteinosis, where look at this CT scan. You can see this diffuse ground glass opacity, and you see that the septae are also thickened. This is because of those debris getting accumulated. This is what has been described as the classic crazy paving appearance. It looks like this pavement within the lung, right? So this is crazy paving appearance seen in pulmonary alveolar proteinosis. Remember, it's a macrophage defect. How do you want to treat it? We got to clean the lungs, right? So this is what you're going to do for this disease, is a whole lung lavage. You have to wash this substance accumulation, and you have to do this recurrent, a number of times. So this is about PAP. The sibling history will be the crucial point here, and the imaging. Apart from this, if they tell you that the baby is preterm, as soon as you hear preterm, you'll think of hyaline membrane. But if the respiratory distress is not at birth, it's not on day 0, but 1 to 7 days, also think of apnea of prematurity. Okay, so in a baby, there can be apneic episodes. But what are abnormal apneic episodes are when this apnea, the definition of abnormal apnea is apnea lasting for more than 20 seconds, cessation of breathing for more than 20 seconds, that should be accompanied either by cyanosis or bradycardia. Okay, because otherwise baby can also, these preterm babies particularly can have these episodes of apnea, but they are problematic if they are for more than 20 seconds plus cyanosis or bradycardia. Okay, so this is apnea of prematurity. If they give you that the baby was on persistent oxygen support, was on mechanical ventilation for a long time, and now you can't take the baby off the ventilator, weaning off is not being possible, then you have to consider a possibility of bronchopulmonary dysplasia. This is something that can happen in babies who have been on long-term ventilation support and then become dependent on it. So this condition where you see these diffuse cystic lesions in bilateral lung, this is called as bronchopulmonary dysplasia. There's a little extra, you just want to be aware of this entity, right? So loads of questions get covered in this particular page, extremely important. There are 2 scores here. The first one is what we call as the Silverman-Anderson score. This is particularly for preterm babies. Whereas this one here is the Downey score. You have been asked, detailed calculation based questions from these. So you need to know everything about these scores. This is for everybody, term as well as preterm. Okay, so let's look at Silverman-Anderson first. You just have to remember there are 3 retractions: upper chest retractions or movement, lower chest retraction, xiphoid retraction. So upper chest, lower chest, xiphoid, Nair's dilatation and expiratory grunt. The points are 0, 1 and 2. 0 or basically 1 by 1, upper chest movement, synchronized, lagging, seesaw. Seesaw meaning paradoxical. So, synchronized, lag, paradoxical. Retractions, none, just visible, easily seen. Same with Nair's, none, just visible, easily seen. And same with grunt, none, just visible ki jagah, heard with stethoscope, and easily seen ki jagah, easily heard by the ear. Okay, so last 4 I think you don't even need to memorize. Nothing abnormal, just visible or heard with steth, easily seen or heard by ear. Okay, so this is about Silverman-Anderson. Downs has 2 things in common with Silverman-Anderson. One is the retraction, which is none, mild or moderate to severe. So remember, moderate comes here. Grunting, none, same, with steth, without steth. So grunting is sorted, okay, grunting, retraction. What are the new things? You have respiratory rate less than 60, 60 to 80, more than 80. If you remember neonatal respiratory distress, if you remember the NRP, we had said in an adult when we do CPR, the breath is 10. In a child, it's 20 to 30. In a neonate, 40 to 60. So can I say more than 60 is abnormal? So you can see how less than 60 is normal, more than 60 abnormal, more than 80 even more abnormal. So that way you can remember the numbers. Cyanosis, none. None with oxygen, cyanosis despite giving oxygen. Air entry, good, decreased, barely audible. So here, respiratory rate is the only thing you essentially remember. It's 0, 1 and 2. Okay, so these are the scores. Next, we talk about one more score that you should have on the tips of your fingers, our APGAR score. So here you have 0, 1 and 2 again. APGAR is an acronym in itself that you can remember. So A for the appearance of the baby, P for the pulse, G for the grimace, A for the activity, and R for respiratory effort. Remember, there is no rate here. There is no rate, it's respiratory effort. A for appearance, completely pink baby. Acrocyanosis, complete cyanosis. More than 100, less than 100, no pulse. Grimace, you will basically tug a catheter at the baby's nose. If the baby gets irritated and cries and pulls away, that's very good. If the baby is irritated, baby grimaces, but it's not putting the effort to remove it, that's 1. And no response, 0. Active movement, arms and legs flexed. Okay, so this is where you have a flexed posturing and then you have extended posturing, no movement. Okay, and respiratory effort, strong cry, slow cry, no cry. So this is how you are going to remember the score. This, remember, is a prognostic score. Have we ever read that APGAR was dictating the resuscitation? Never. We are not going to measure APGAR to guide resuscitation. The only thing that guides resuscitation is heart rate, if you remember. That was the only parameter we were checking. So you want to remember, this will not guide resuscitation in any way. This is only to say the prognosis of asphyxia. So the timing of the score is, it's measured at 1 minute and 5 minutes. And if the score is less than 3, it is the criteria of severe asphyxia. Apart from this, pH less than 7 is also severe asphyxia. This is a repeat question, and hypotonia. So 3 things: severe asphyxia, less than 3 APGAR, pH less than 7, and hypotonia. Right? So that's a question. With this, we go into hypoxic ischemic encephalopathy. Before I talk about HI, I want to talk about neonatal seizures first, because HI usually presents with neonatal seizures. So the drug of choice for neonatal seizures is phenobarbital. So now we have studied 2 places where phenobarbital is used. One is going to be in Krigler-Najar 1 versus 2, whereas this is where it is the drug of choice. We don't use barbiturates in adults because they have this risk of dependence. How will a neonate get dependent? Even if they do, how will they say it? So we can give, okay? So that's how you want to remember. Phenobarbital is the drug of choice. The most common type of neonatal seizures are subtle seizures. They are going to be this grimacing movement that you will not even notice. So subtle seizures, very, very important. The most common cause, HI. There could be other causes, predominantly electrolyte disturbances. So you can have hypo and hypernatremia that can cause seizures. Hypocalcemia can cause seizures. Then you want to remember pyridoxine deficiency. That's why you would have read that pyridoxine is used for refractory neonatal seizures, right? So pyridoxine deficiency, because we have learned that pyridoxine B6 is what converts glutamate to GABA, right? So at least you can increase levels of GABA and control the seizures. And very, very important, hypoglycemia. So hypoglycemia, what is the definition? This is a little controversial, but you can remember this. So the blood values, O is 40 mg per dl, whereas plasma is less than 45 mg per dl. So blood has an O, that's how you can remember. Blood less than 40, plasma less than 45 mg per dl. Usually in practice, you will just remember 45. Any 45, if you see, it's less than 45, just have to start treatment. Okay, so that's what you want to remember. Even though this is the technical definition, you can remember that, it will be given differently in different sources. But plasma or anything less than 45, if they are asking in those language terms, you have to go for it. But this is the correct definition. Best prognosis, it's with the focal clonic type, whereas worse prognosis is in the myoclonic type of seizures. Okay. What you want to remember for neonatal seizures, the bedside monitor that can be used. This is the bedside monitor. This is amplitude integrated EEG. So normally, EEG is a very complicated procedure where you will have a lot of scalp electrodes, etc. This is a summated one electrode EEG that you want to remember. So this is what it looks like. Apart from that, two investigations very, very important. The first one is transcranial ultrasound. So this is what is neurosonography or transcranial ultrasound, where we put our probe on the anterior fontanelle. The anterior fontanelle fuses at around 1.5 to 2 years. So till that time, it's a diamond shaped window to the brain. So that's where you keep the probe, and you can see. In adults, we can't do because the fontanelle is fused. The bone can't allow ultrasound waves to pass through. But in a baby, in a neonate, until the anterior fontanelle is open, that gives you a window to the brain. And that's what you see. So look at this. This is a transcranial ultrasound. These are the ventricles that you see here. In the center, the part you see, remember in anatomy, we had studied septum pellucidum. This is what we call as cavum septum pellucidum. So in newborns, you have this fluid-filled septum pellucidum that's called as CSP. Not very important, but what you see here is this hyperechoic area around the ventricle. This is what is indicating a periventricular hemorrhage. So periventricular hemorrhage is one of the complications that happens with preterm babies, okay? So in preterm babies, you have the germinal matrix. This germinal matrix is present around the ventricles. These are these vessels which can lead to bleeding, okay? So you want to remember germinal matrix hemorrhage, periventricular hemorrhage, something that happens in preterms more commonly, and for that the investigation of choice is transcranial ultrasound. Okay, so transcranial ultrasound, remember, investigation of choice for periventricular hemorrhage. Now, this hemorrhage is later on going to get converted to white matter abnormalities. That is what we call as periventricular leukomalacia, right? So, in a preterm, the pattern is periventricular leukomalacia, and this is what results in spastic diplegia. Smaller baby, smaller deficit is what you want to remember. Whereas for ischemic insult, right, if the oxygen gets cut off during birth, what we call as birth asphyxia, for ischemia, the investigation of choice is diffusion weighted imaging, that is essentially MRI. So this is what the DWI is, and you can see how the metabolically active areas like the basal ganglia in this case are showing white nature, indicating diffusion restriction. So to pick up ischemic changes, DWI is the best. For hemorrhage, first and the best is ultrasound, okay? So what are the patterns? So the resultant deficit, because all of this stuff happening in the brain during birth asphyxia, is going to result in cerebral palsy. Very, very important. Cerebral palsy is non-reversible and it is a non-progressive disease. It's a very commonly asked question that can I give DPT vaccine? So DPT vaccine can be given. DPT is contraindicated in progressive disorders like progressive encephalopathy. Spastic paralysis or cerebral palsy is a disease that is non-progressive. Okay, so you want to remember progressive encephalopathy is a contraindication to the pertussis component of DPT, right? So that's what you want to remember. Spastic type is the most common. So what you see in a term babies tend to have parasagittal. They tend to have insult around parasagittal, whereas preterm have periventricular insult. So this is a very, very underrated topic. You get a lot of questions from this box right here. So parasagittal injury is going to result in spastic quadriplegia, right? So you want to remember term baby, more insult, preterm baby, diplegia. Whereas the most common is status marmorotus, where you have basal ganglia, metabolically active areas affected, like I showed you on the MRI. And this is what is going to result in the chorioathetoid type. So essentially, this is the most common type that you want to remember. That's the most important part. Few signs. So these babies with spastic type of cerebral palsy or any cerebral palsy in general will have a lot of their primitive reflexes which don't go away. So we'll also see that the Moro reflex will persist. They have this cortical thumb, right? They'll put their thumb like inside its cortical thumb. That's one sign. They will have commando crawl, right? So commando crawl, spelling I have messed up, can happen. When the baby grows up, they can have a scissoring gait. So these are a few markers of cerebral palsy, right? So this is about HI. We have a staging system of HI. This is called as Sarnath and Sarnath staging. You have to write the same name 2 times. Here, it's pretty simple actually. Focus on the buzzwords. Stage 1 is where everything is increased. The baby is actually hyper alert. So, hyper alert baby. You have overactive stretch reflexes. You have strong moros here, mydriasis, tachycardia. Stage 2, now everything starts to decrease. Lethargic, activity decrease, the reflexes decrease, meiosis, bradycardia. What is unique here is seizures. If you see seizures, that's stage 2. Stage 3 is where everything from decrease is gone to absent. So this is where you have no activity. Baby is in coma. There are absent moro reflexes, primitive reflexes. So that's what you want to remember. So hyperactive, seizures, gone. These are the 3 stages of Sarnath and Sarnath. Moving on to what are the neonatal reflexes. So this is very important. So look at the first one, the cute milestone where baby will grasp onto any finger that you give the baby. So this is palmar grasp. So now you need to know when does it appear and when does it disappear. Palmar grasp will appear at 28 weeks and it disappears by 3 months. Okay, so we'll study in milestone as well. The time when the mother is recognized by the baby is the time when palmar grasp goes. So how I remembered it, the baby now recognizes mother. So now the baby will not hold on to any finger which is offered. Okay, only mother's finger baby will hold on to. So recognizes mother and palmar grasp disappears, come at 3 months. Then this is the rooting reflex. Rooting reflex is a feeding reflex. So this is where you stroke the mouth of a baby. Baby will open the mouth expecting milk, right? So this appears at 32 weeks. And this is the first one to disappear at 1 month. So this can be a question, which is the first one to go. So this rooting reflex is the one that disappears at 1 month. Look at this. This is what is most commonly asked. Is this symmetric tonic neck reflex or asymmetric tonic neck reflex? So you want to remember this is asymmetric tonic neck reflex. How to remember? Look at this. You turn the head onto this side. The ipsilateral arm extends. I know you can't see that, but can you see the contralateral one flexing? So the ipsilateral is extending. So this is where vowels stick together. That's how we're going to remember. Asymmetric matlab ipsilateral extend. Symmetric matlab ipsilateral flexed. No vowel. Fine. So that's what is very, very important. So ASTNR, you want to remember, appears at around 35 weeks and disappears at 6 months. Okay. Then comes the most important one, Moro's reflex, where you put the baby down. Like if I make you fall from the sky, when people skydive, what do? Their arms are going to open up. So the arms are abducted, extended, and the palms open. So it's a stepwise process that happens. Very important. If they ask you about when does it begin to appear, it begins to appear at 28, but when is it completely present? 37. So it appears in stages from 28 till 37 weeks, it's completely formed. Disappearance, 6 months. Okay, so disappearance is the same. Then there are 3 reflexes which appear after birth, very important. So one of it is symmetric tonic neck reflex. So this now you know that when you will put the head on one side, what is going to happen? The ipsilateral arm is now going to flex, right? Apart from that, you have Landau's reflex, which appears after birth, and you have parachute. So this is what image is showing, parachute reflex. Now opposite of Moro's, you will put the baby in prone and then you will bring the baby down. So this position is like a parachute. This is the one which appears at around 8 months and this is the one which never disappears. So this is the only one primitive reflex or neonatal reflex which never disappearance, all right, which never disappears, right? So that's what you want to remember. Few one-liners about Moros. So persistent Moros, as we discussed, is a feature of cerebral palsy which will actually have a lot of primitive reflexes which are retained there. Exaggerated Moros we just saw was HIE Sarnath stage 1, whereas absent is HIE stage 2 or 3. It can also be absent in Down syndrome, and it can also be absent in Kernicterus. Asymmetric Moros, very important, you want to remember, will be any birth trauma, right? Essentially asymmetric because there is some problem. Either it could be Erb's palsy. Remember Erb's palsy where C5, C6 nerve roots are gone. So there will be asymmetric. You may have birth trauma. Fracture clavicle is the most common fracture at birth. That will result, or any other trauma, fracture humerus, right? So this you can just see the options and decide. So these are your questions from neonatal reflexes. So next we talk about feeding, right? So this is very important, very conceptual, right? So just understand the concept of why we are using a certain method and this becomes very easy. So any baby less than 28 weeks period of gestation is too weak a baby. They don't even have gut motility which is present. So this is where you have to now rely completely on IV fluids. 28 to 31 weeks, now the GI is normal, okay? So we can give enteral feeds, but the mouth is still not working. There's no sucking burst developed, but there's no coordination between suck, swallow and breathing. So this is where you're going to give orogastric or nasogastric feed. So this is an image-based question here. So this is what is called as a gavage, right? So this is where you are now going to start breastfeeding. But you use basically a gavage method or a nasogastric orogastric pipe here for feeding. 32 to 34, now the coordination begins to develop. So we will rely on spoon feeding, but the sucking pattern is still not mature. So this is what you use. So you use a spoon, or this is something commonly used in our country. This is called as paladi, right? So paladi or spoon you will use to feed. More than 34 weeks, now everything is good to go. Breastfeeding. So any baby more than 34 weeks breastfeeding, remember three numbers, 28, 32, 34. Below that, IV fluids, 28 to 32 gavage, 32 to 34 paladi, more than 34 breastfeed, right? This was a FMG question this time, that how much is the fluid requirement? So depends on the weight, right? So unless they give you that baby is very low birth weight, you have to go for 60 ml per kg. So in extremely small babies, like very low birth weight babies, you will give 80 ml per kg, higher, but otherwise 60 ml per kg is what is recommended, and after 1 week you will increase to 150 ml. For example, normal weight, if you consider 3 kg, so a 3 kg born baby will need up to 180 ml in a day, right? So this is per 24 hours, 180 ml of milk they need to be provided with, and after 1 week this will increase to up to 450 ml. Fine, so this is what is important number. Nowadays they're asking a lot of questions from fluid and you know, numbers behind that. So that's what I'll be teaching you. Necrotizing enterocolitis, very important. The risk factors, preterm, formula fed babies and babies who have a patent ductus arteriosus. So this is unique, you might forget this. This is what we have to learn here, is the modified Bell's staging. So what is the stage? You want to remember 1A, remember BAT. Bradycardia, apnea, temperature instability. This is 1A. 1B, B for bloody stool. So these are both clinical criteria: BAT, bradycardia, apnea, temperature, bloody stool. 2A is now radiological. So you see pneumatosis intestinalis. 2B, portal venous gas. So 2A, what is pneumatosis intestinalis? This is air which is trapped in the bowel wall. So if this is the bowel wall, within the layer, within the mucosa, submucosa and you know the layer of the intestine, you have air which is entrapped. So from the lumen it has come into the wall. So this is what looks like this linear lucency. Can you see this line here? So this is what is pneumatosis intestinalis, which is air trapped in the bowel wall. It is this linear line that you will see along the bowel. Pneumatosis intestinalis. A stage higher than this is going to be air that reaches the portal vein. So can you see this in the liver? Can you see this branching lucency here? This is what indicates portal venous gas. Okay, so you want to remember 2A pneumatosis, 2B portal venous gas, 3 now. So in 3 letter word DIC, and 3B is the final stage where now it perforates to become pneumoperitoneum. So see this image. You recognize the football sign we have studied. You see air encircling the lesions, all of the viscera in the abdomen. So this is what is called as football sign, indicates perforation, pneumoperitoneum. This is the stage where you will have to operate. Before this stage, the management is nilperoral. You'll give antibiotics and you'll give fluid resuscitation. So essentially NPO, fluid and antibiotics you want to give. Surgery indication pneumoperitoneum. So just to recap, what was 1A? 1A matlab bat, 1B, B for bloody. Then you have 2 radiology things, 2A matlab pneumatosis, 2B matlab portal venous. 3A, 3-letter DIC, 3B perforation. So this is modified Bell staging for you. Torch infections, getting a lot of questions from this, very, very important. So what you have to remember, hydrocephalus, chorioretinitis, parenchymal calcification. This is what is toxoplasma, right? We had studied in chorioretinitis how there is this headlight in fog appearance. If left untreated, we will see a macular scar. Do you remember this? So this is toxoplasma. Parenchymal calcification is the hallmark. Very, very important. Next one is CMV. So this is where you have microcephaly. What is microcephaly? Microcephaly definition you want to remember, less than -3 standard deviation of head circumference is the definition of microcephaly. You have periventricular, V for V. In toxo, it's parenchymal. Here you have periventricular calcification. The most common long-term sequelae, remember, is SNHL. And this time aims adult, SNHL is more common in babies who are symptomatic at birth or asymptomatic at birth. Obviously, this is something which is more common in patients who were symptomatic at birth, right? They will have more common, but both can be seen. Most babies are asymptomatic at birth. So 90% babies are going to be asymptomatic. And what you do here is a PCR detection in the baby. Usually for all of the torch in general, you'll take urinary or saliva samples. This is better than blood PCR because viremia to develop will take some time. So urine and saliva are the best samples for doing PCR, okay? But blood PCR can also be done. CMV is overall the most common torch infection you want to remember, okay? So these are many questions from CMV which are asked. If they give you calcification with microcephaly, but the calcification is at gray matter, white matter junction, this is Zika virus. This has been asked as a life cycle image based question where they'll definitely give you Aedes mosquito in the picture, right? So look at mosquito, microcephaly in baby, Zika virus. Next, skin rash and limb hypoplasia. So this is what is varicella. Okay, so this is congenital varicella. But what is important is neonatal varicella. When do I have to give immunoglobulin? So look at this number. If the mother develops a rash either 5 days before the delivery or 2 days after the delivery, this is where the baby has been exposed and now you need to give varicella zoster immunoglobulin to the neonate. Meaning, what is the time where the infection can be transmitted? So either the mother developing rash 5 days before delivery or 2 days after delivery means the baby has been exposed. You have to give the baby varicella zoster immunoglobulin. Okay, so this is what is very important. Skin and eye lesions or encephalitis, this is seen in herpes, HSV1 or HSV2. So this is very tricky. We have studied encephalitis as HSV1, but what gets transmitted as a torch infection would be HSV2, right? Because if the mother has active genital herpes at the time of delivery, now the baby is going to acquire that. So the only way to prevent this is LSCS. Vaginal delivery should not be done if the mother has active genital herpes. Same goes with active genital viral warts. It's studied in ENT that a baby is going to then get papillomatosis. So that's where you again avoid that vaginal delivery. Very, very important. This is congenital rubella syndrome where you will have SNHL cataract. The cataract we had studied. So the most common one is nuclear pearly cataract. But apart from that, we had also studied zonular or lamellar. That is something which is typical in rubella. Overall, most common eye is not cataract. It's a part of the triad, but most common eye feature is salt and pepper retinopathy, which I had taught you in ophthalm, right? So this is salt and pepper retinopathy. As far as CVS is concerned, patent ductus arteriosus is more common than pulmonary stenosis. And very important, this is the infection with the least risk of perinatal transmission. And even if it has to transmit, it's usually in the first trimester. Okay, so maximum before 11 weeks. And extremely important, parvovirus B19, you know, is the most common infectious. Overall, non-immune eye drops, most common cause is CVS anomalies, but most common infectious cause is parvovirus because it attacks the erythroblast, causing pure red cell aplasia, leading to anemia, leading to non-immune eye drops, right? So this is about the torch infections. You've gotten a lot of questions in the recent times, okay? Moving on to acute diarrhea now, again a standalone GI topic. So now neonatal is done, going on to other niche pediatric topics. So acute diarrhea, you need to triage. They ask you questions from the classification. So no dehydration, matlab normal child. Some versus severe we need to remember. Some dehydration, the baby is going to be restless, irritable. Very important, the baby, if you give them fluid, is going to be very thirsty and drinks eagerly. These two features I feel are very subjective, right? So eyes sunken, skin pinched slowly, not very reliable. Severe dehydration, you want to remember? Lethargic, unconscious. Baby is not even drinking now. So these two features very important. Eyes very sunken, skin pinched very slowly, right? So some dehydration, this is where you're going to do plan B. Plan A matlab no dehydration, give as much as the baby wants. Plan B matlab some dehydration, where the criteria is 75 ml per kg over 4 hours you have to give, because the baby most of the times can drink orally, prefer oral, if not give IV. Severe dehydration, this is the plan C, very important. You have to give 100 ml per kg, which is divided into 30 and 7. So if the baby is small, less than 1 year, give it in 1 hour and 5 hours respectively. If the baby is bigger, half kar do. So this becomes half hour, this becomes 2.5 hours. Okay, so this is what is the fluid resuscitation. Now, what is the fluid of choice? So you want to remember the fluid of choice is ringer lactate plus 5% dextrose, right? So that's the fluid of choice for treating severe dehydration. This is where you will only give IV because now the baby is not going to be in a state to drink. Apart from that, all children with acute diarrhea should be given zinc for 14 days because it helps with the healing, right? Remember, zinc deficiency was leading to acrodermatitis enteropathica. So it does have a role in diarrhea. So zinc deficiency you don't want. So less than 6 months, you give 10 mg, more than 6 months, 20. If they don't mention, remember 20 mg for 14 days is to be given for every child. So this is about acute diarrhea. While we are talking about this, let's talk about everything fluid, right? Now becoming very important. So first I want to talk about ORS. So what we use is reduced osmolarity ORS. Don't confuse it with Risomal, okay? Because ye padke bhi it will seem like reduced osmolarity. This is basically for malnourished, rehydration solution for malnourished, okay? So what is reduced osmolarity ORS? Previously we were using standard ORS, now we have switched on to reduced, where sodium and glucose are the same, and the concept behind this is intestine has SGLT1, remember, which is sodium glucose co-transport. So the absorption is much better if both of them have the same composition. So this is sodium and glucose. Then you can see chloride is 65, citrate is 10. So this became 75 and potassium is 20. So together this becomes 245. If you want, you can remember the previous values as well. And it will be a good idea to just go through Risomal. The difference is now there's a gross discrepancy between glucose and sodium. You have higher levels of potassium here, and you are giving other micronutrients like magnesium, zinc and copper. The overall osmolarity is higher. Okay, so you can just read this. In fact, if you want to go one step ahead, reduced osmolarity ORS packet, you should at least see the grams also of each of these components. That's just a bonus that you can do, but this is something you definitely should remember. Apart from that, they've also asked you this, composition. Here, keep it simple. The moment you see lactate, right, it has to be ringer lactate. So essentially what you want to remember is either saline or Hartmann solution. Hartmann solution is almost equivalent to ringer lactate. So NS has only NS. It has sodium chloride. It has 154 milliequivalents of NaCl. That's all. There is nothing else here, and the ratio is 1:1. Whereas in Ringer's lactate, you have sodium, which is more than the chloride, you have potassium, you have lactate, you have calcium as well. So as you can see here, there's sodium chloride, there's potassium chloride, and there's calcium chloride, right? So that's what you can remember here. So you can just distinguish them very superficially as well. If there's anything except NaCl, it's Ringer's lactate. Very important, fluid for maintenance in children is N/2 plus 5% dextrose. This is the fluid of choice. Apparently, when this came in the exam, this was not in the option. In that case, go for N plus 5% dextrose, okay? But I've seen some questions where they have given both options and still marked N plus 5% dextrose. I think that's not correct. You have to remember this is the best fluid for maintenance, and they've also asked you how much is to be given. So, for the first 10 kg, you are going to give 100 ml per kg. For next 10 kg, 50 ml. For next 20 ml per kg. For example, if I give you an example that there is an 18 kg baby, what will be the fluid maintenance for over 24 hours? So, for the first 10 kg, 100, matlab 1000 ml ho gaya. And then for the remaining 8 kg, 8 into 50. So, 8 into 50 equals 400. So, the total fluid becomes 1400 ml over 24 hours, right? So, this is what you have to do to calculate the maintenance fluid. So now we talk about GI emergencies. Now this is a topic which we have covered in detail in radiology. So I'm just going to rush through it so that you get to see, in a nutshell that what are the different presentations and what's the pattern approach. In detail, we have studied these already, okay? So look at the first one. What do you think is the diagnosis? So whenever you see on ultrasound, there is this appearance where there is one bowel within the other bowel. You know that this is intersusception. So intersusception is telescoping of one bowel into the other. Frequently, they'll give you history of rotavirus vaccination. You know that the most common intersusception is the ileocolic type, because ileum has the Peyer's patches which will proliferate around 6 months, and that is something which will cause the intersusception, right? So that's the theory you know. The first investigation here is ultrasound. So initial investigation, ultrasound, which will show you this bowel within bowel appearance called as target sign, donut sign, sandwich sign, pseudo kidney sign, whatever you want to call it. Basically, one bowel within the other bowel. Then they'll give you what is the best investigation. So you know that the gold standard here is a barium enema. Barium enema or air enema or saline enema. Anything that they give you, what do you have to do? You're gonna give the barium from the other end, and what it creates is this hydrostatic pressure. So because of this hydrostatic pressure, now what's gonna happen? First of all, at baseline, you see this claw. This is the claw sign. Because of this hydrostatic pressure, now the bowel comes out. This is what is called as coiled spring appearance. So this is the coiled spring appearance, which indicates that this is getting reduced. So this is where the reduction is working. So this is how you manage intersusception, and that's what you know. Now the other possibility here for patients who present to you with what is called as red currant jelly stool. Now, intersusception can also have red currant jelly stool, but you'll also have pain along with that. The child will be crying. Whereas here what you have is a painless red currant jelly stool. That is when you want to suspect a Meckel's diverticulum. So, what is this investigation here? So, for Meckel's diverticulum, remember the investigation of choice is technetium 99M per technate scan. So this is your technetium per technate scan. It's the per technate which binds to the stomach mucosa, and that is what is present in Meckel's. So basically you remember the rule of two. There are two mucosa here. What are the two mucosa? It's the stomach mucosa, and that is responsible for the hotspot on pertechnate, and you can also have pancreatic mucosa. Pathwise, what is the term we use for such a lesion where normal tissue is present in abnormal place? Hamartoma or choristoma? This is choristoma. Hamartoma is abnormal tissue present in normal location, right? So this is an example of a choristoma. So this is first rule of two. Meckel's is nothing but a diverticulum that is arising. It's from the vitalointestinal duct, right? So it's a diverticulum from that which is present in 2% of the population. You want to remember the size is 2 inch and it is 2 feet away from the ileocecal junction. It is present on the anti-mesenteric border, and you want to remember it is more common in males as compared to females, right? So this is about Meckel's diverticulum. Next, you have a child here who's presenting with what kind of vomiting? Non-bilious vomiting, right? So as soon as you hear non-bilious, you have your answer. Projectile non-bilious vomiting. They'll give you that the baby has an olive-shaped mass every time after the baby feeds. They might give you left to right peristalsis, which is a repeat question. What are we talking about? We're talking about congenital hypertrophic pyloric stenosis. This is where the pyloric muscle is so hypertrophied that the canal undergoes narrowing. So what do you see here? You can see how the pyloric muscle is thickened. Two values I had taught you, 4 millimeters thick, 16 millimeters long. So this is where ultrasound is the investigation of choice. Remember this, and this is where the definitive management was Ramsted's pyloromyotomy. But before you go to the definitive management, there is some electrolyte imbalance that you need to correct. So what is the usual electrolyte imbalance? Vomiting, meaning you are losing acid. So this is where you're going to have metabolic alkalosis. But because the baby is also losing a lot of water, a lot of fluid, there is dehydration. So renin-angiotensin aldosterone pathway becomes activated. What does aldosterone do? It causes potassium H plus secretion. So now as it is we are losing acid from the vomit, now we are also losing it from the urine. So this is why it is referred to as paradoxical aciduria. Okay, so this is where you will also have hypokalemia, hypochloremia, hyponatremia, right? So this is the kind of presentation that you're gonna have. Moving on to this part here, so this is where you can see that there are two bubbles, double bubble sign. This is where you will be getting bilious vomiting more commonly. So what is this? Double bubble sign. So double bubble technically can be seen in 3 places, but you want to remember the first possibility is duodenal atresia in a child, right? So duodenal atresia more commonly associated with Down syndrome. Other possibilities could be annular pancreas and also LAD bands. LAD bands are associated with malrotation, okay? So these are the two other differentials for the double bubble appearance. But you want to remember, duodenal atresia most common. I've also seen triple bubble with jejunal atresia. Look at the next one here. What do you see? You can see that this is the gut which is rotating on its own axis. So this is what is the corkscrew appearance. So this is corkscrew appearance seen with midgut volvulus. Midgut volvulus happens with malrotation. So midgut volvulus with malrotation, this is what you are seeing on this contrast study. Again, you would be given bilious vomiting here as well, and you want to remember you will do a upper GI contrast study. You will not give barium, right? Any of these babies in obstruction will not give barium. What we will do is a contrast study with iohexol. Okay, the next one, This is where they'll give you the history that the baby has not passed meconium for more than 48 hours. Remember, meconium not passed in 48 hours is abnormal. Urine more than 24 hours. This is also a little controversial, but this is the consensus you want to remember. So, if a baby has not passed meconium for more than 48 hours, always consider the possibility of Hirschsprung disease. So, this is where you have the failure of neural crest cells to migrate. So, neural crest cells have not migrated onto the rectum. So now what happens? The plexus, the myenteric plexus does not form here. So we have two kinds of plexuses. We have one in the submucosa and one within the muscles, which is the Auerbach's plexus, which is between the two layers of the circularis and the longitudinal muscles. So muscular layer and submucosa. This was also asked as an image-based question in the NEET exam, right? So you want to remember that these motility plexuses are not there. So what's going to happen? Now the rectum does not have peristalsis because it doesn't have these mucosal plexuses. So now because of failure of peristalsis in this part, what happens? The sigmoid becomes dilated. So this is very important that even though we say Hirschsprung is sigmoid megacolon, is it really sigmoid's fault? No. It bichara is just dilating in response to rectum not moving. And we have said sigmoid, you are megacolon, but it's not its fault. So that's what you want to remember, that this is Hirschsprung disease where the problem is in the rectum. You don't have the myenteric plexuses. Alright, so Hirschsprung disease, the first investigation you'll do is a barium enema where you'll notice that the sigmoid is dilated more than the rectum. Okay, so that's the finding. You see that sigmoid megacolon. This is Hirschsprung disease. The investigation of choice is to do a punch biopsy and actually see that these nerve trunks are absent, and we can also do one acetylcholine esterase stain which will not stain any nerve trunks because there are none. Okay, so this is what you need to remember, and eventually the treatment is surgical. So whatever part is agangliononic, you are going to remove it and you are going to do these pull through procedures. Okay, so various named procedures, you will just basically remove the non-neuronal segment. Okay, so these are your multiple GI conditions which get you questions. One more condition, this is where they'll give you the history of a newborn with drooling and difficulty feeding. Don't confuse this with choanal atresia. There they'll give you cyanosis while feeding. Okay, this is where you have drooling and the baby is not able to feed because there is an abnormal communication between trachea and esophagus. So this is tracheoesophageal fistula where you have an abnormal communication, and during the budding, basically when the foregut is developing, it is joined to the trachea, but then they have to undergo separation. Here that separation didn't happen. So now every time the baby feeds, they'll aspirate some of the milk, resulting in difficulty breathing. So this is what you want to remember. So how do you see this? So anytime you have a case, you have to first start with the appearance of the stomach. Is the stomach gas present or not? So there are 5 types. Look at this. So type A and B, you can see that there is no distal communication of the esophagus. So this is where you will not see any gas in the stomach. That's how your approach should begin. If you see that stomach gas is present, it is what is C, D or E. Okay, so the most common type is type C. Look at what is going to happen here. So this is where if you put an NG tube, now the NG tube will be coiled in the proximal segment. So that's what you can see on the X-ray, and you will have fundus gas. Here the NG tube will not remain coiled in the proximal segment but will enter the trachea, right? So that's what you will see here. And E is the one which presents very late. This can present late in a child with recurrent pneumonia. So rather than the classic presentation that the child is aspirating while feeding, drooling saliva, this one presents as recurrent chest infections because here you have an H-typed fistula. So basically the baby can feed normally, but some micro aspiration will keep happening, resulting in recurrent pneumonia, right? So this is the one which presents late. A and B, look at this, there will be no gas in the stomach. In A, it will coil. In B, it will go inside. So look at our case. First of all, no stomach gas, matlab it is either A or B. Now look at what is happening with the NG tube. You can see how NG tube is actually going inside. It's going into the airway. On the other side, it's going into another airway, which indicates what? That it is not A, it is B type. So this is how you have to approach the types. Whereas the H type fistula, we will not be able to make a diagnosis without doing a contrast study. So this is where you do a hyohexol study. You're going to inject a water soluble contrast, and look at this. When the baby is, we are not going to inject, basically we are going to put an NG tube, right? This baby can't really swallow, so it's very difficult to do a counterpart of barium swallow, because the baby will not swallow at will, right? So it becomes difficult. So what we do is we put an NG tube. While coming up, we keep injecting the contrast until you see the tract. So entirely while pulling up, we keep visualizing and looking for this fistulous communication. Sometimes even then you can't see the H type of fistula. Then you will have to do a combined esophagoscopy and bronchoscopy to visualize the fistula, right? So this is the H type. So this is what you need to know about tracheoesophageal fistula. You know that it's associated with VACTERL. What is VACTERL group of abnormalities? You have vertebral anomalies like hemivertebrae, etc. You have anorectal malformations. You can have cardiac anomalies. You have tracheoesophageal fistula. You can have renal abnormalities and limb anomalies like radial ray. So remember, radial ray deformity we had studied with Fanconi's anemia. It can also be seen with VACTERL, right? So that's what you want to remember. While I'm talking about ARM, another tangent, you can just remember ARM is associated with two different anomalies. What is ARM? Anorectal malformations. One is VACTERL. The other thing is it is associated with sacrococcygeal teratoma. Can anybody think of a syndrome here? So this is extra edge point for you, that ARM plus sacrococcygeal teratoma, this is the Currarino syndrome. Okay, so this is Currarino's syndrome, right? So this is what you need to remember about tracheoesophageal fistula. Now, extremely important, like AIIMS will love to ask you cystic fibrosis. Almost every exam you get a question from this. So first of all, the chromosome is 7. The mutation is delta F508. So this is the exact mutation that happens for the CFTR channel, which are the chloride conductance channels. The most common class of mutation is class 2 mutations, which are called as trafficking type of mutations. We will get to the treatment, but first let's understand the problem. Now, these CFTR channels conduct chloride. You want to remember, it's a love triangle. It's not even a love triangle, it's a trio. Wherever chloride goes, sodium goes. Wherever sodium goes, water goes. So essentially, if chloride can't go, water is not going to go. It's a group of 3 friends. Whatever they do, they'll do it together. So now when chloride doesn't go, what happens? Water will not enter the duct. Means the secretions everywhere in the body become very, very thick, and that will result in blockade of the ducts. Except sweat. Sweat, the role is opposite for these channels. The role is to reabsorb chloride. Reabsorb chloride means reabsorb sodium. If you can't do that, they'll be very salty sweating. So this is what is happening. So now, what did we understand? If the CFTR channels don't work, what's going to happen to the chloride levels in sweat? Sweat is going to be opposite, where the chloride levels increase. Everywhere else, all the other ducts of our body, be it biliary channels, pancreatic duct, respiratory duct, sinuses, what's going to happen? All of these ducts, because the chloride levels are down, the secretions become very, very thick, and that is where you have obstruction, and that is what results in the dysfunction. So this is how we have to learn the manifestations. So look at this. Everywhere you have infections because of duct problem. Sinusitis. You have recurrent respiratory infections with bronchiectasis. Salty sweat. Bile ducts are blocked. Pancreatic ducts are blocked. Intestines. Again, you will have intestinal obstruction. What happens in reproductive organs? Is there male infertility or female infertility or both? The answer is both. In males, what happens? Now, because you have cystic fibrosis, we have learned something in obs-gynae as well. You are going to have bilateral absence of vas deferens. That's an association leading to male infertility. In female, what happens is the secretions. In female, what happens is the secretions, the cervical mucus becomes very, very thick, okay? So, that will not allow the sperms to enter. So, the cervical mucus becomes very thick. So, there will be male and female infertility here. Intestinal manifestation, also remember meconium ileus, okay? So, meconium ileus is this thick inspissated meconium that happens because of the same concept, right? So, in utero, you can have meconium ileus, the thick impacted meconium. Means what? The contrast or the meconium, not the contrast, the meconium never reached the large intestine. So, that is what results in microcolon. So, what you see is that there is impacted meconium with a microcolon. That's the appearance you see. Something very important about meconium ileus, you don't see air fluid levels. Other places, whenever there is obstruction, you see air fluid levels, not in meconium ileus, because no air was allowed to pass through because of the thick nature of the meconium, right? So, no air fluid level. A lot of times just doing a gastrographin enema can clear it. So, a lot of times the gastrographin enema that we do to diagnose it becomes therapeutic. So, it is diagnostic and therapeutic, but if not, there is a specific surgery that you can remember that's called Bishop-Koop operation. Fine. So, this is about meconium ileus. As far as respiratory infections are concerned, you want to remember that there is bronchiectasis. The most common infection in children less than 16 years, it's going to be S. staph aureus, whereas more than 16 years, we remember Pseudomonas, right? So, Pseudomonas is most common. Burkholderia is something which is very specific, not very common, right? So, these are all your clinical questions on cystic fibrosis, very, very important. Diagnosis, either you have a typical finding or it was picked up on screening or you have family history plus some biochemical evidence. So, this image here we are doing the sweat chloride testing. So, the sweat chloride should be more than 60. That's what we learned, that the chloride levels increase on 2 separate days, and this test is called pilocarpine iontophoresis. What is pilocarpine? It's a cholinergic drug, right? So, you are not going to sweat just sitting there. So, we inject pilocarpine, the sweat will be then measured. You can also do nasal potential difference or demonstrate the mutations. Treatment, now we have targeted treatment which is called Trikafta. Kafta meaning you are enabling these CFTR channels to function more. So, it's a combination of 3 drugs. You can remember Alexa. Alexa is a very tease girl, very sharp girl who will tell me, ma'am, you have told this wrong. This is a correction. So, these correctors are tease people. So, Alexa tease corrector, whereas whatever is left is your potentiator. Okay, so we use a combination of corrector and potentiator to potentiate the existing CFTR channels. Alright, so this is all about cystic fibrosis. The inheritance is autosomal recessive. Like all other metabolic disorders, it's autosomal recessive. Next, we talk about congenital heart diseases. So, this is where I'm going to teach you approach, right, method, rather than just telling you that boot-shaped heart is tough. It's not going to help anyone. You need to have a thorough approach in your mind as to how are you going to approach a case. What are the points to be looked at? And believe me, the shape of the heart on the X-ray is the least important thing here in practice. So, a few one-liners first. So, overall, what is the most common congenital heart disease? It is VSD. The most common one to be affected by infective endocarditis is also VSD. But the most common cyanotic heart disease, remember, is tetralogy of Fallot. But if they ask you what presents in neonates, so now TOF has a later presentation usually around infancy. So if they ask you in neonates, it's transposition of great arteries. The most common cause of death in the first week is hypoplastic left heart syndrome. This is the most serious illness because the left heart doesn't work, there is no systemic outflow. So this is where you usually have mortality in the first week itself. You have gotten questions from the NADA's criteria. So remember, any systolic more than 3, any diastolic, cyanosis or congestive heart failure are major criteria, whereas grade 2 or less systolic murmur, second heart sound, ECG, chest x-ray, BP, your other ancillary findings are minor. So just remember the 4 major, it's very easy to remember. Now, what I am teaching you here is how do you approach cyanosis in a neonate. So clinically, this is what they call as the hyperoxia test. Okay. So a baby with cyanosis could either be a respiratory issue or a heart issue. So how we have to differentiate is give 100% oxygen and then see what is the PO2. If it is more than 300 means everything is normal. If it is improving but not beyond 300, so 150 to 300, this indicates that there is likely a pulmonary disorder or could be CNS disorder or methemoglobinemia. But if it doesn't improve, either remains less than 100 or 100 to 150 means it's a CVS issue. Don't need further details, but still if it improves to a certain extent, it is either primary pulmonary hypertension or it is a mixing lesion with increased blood flow. So this is what we will learn now. What is plethora? What is oligemia? So plethora indicates that the blood flow, the pulmonary arterial blood flow is increased. Okay, so what I mean by increased pulmonary blood flow is plethora. So your plethora lesions will improve more, whereas those with restricted pulmonary blood flow or with parallel circulation will not improve. So decreased pulmonary blood flow matlab oligemia, because pulmonary blood flow is decreased, now no matter how much oxygen you give, the blood flow to the lungs is reduced here, right? So that's what is the concept here. Fine. So this is the hyperoxia test. Now let's begin with the approach. So the first thing is acyanotic heart disease. So acyanotic heart disease represent your left to right shunt. That's why there is no cyanosis, because there is no mixing of the deoxygenated blood. So this is left to right shunt. 4 diseases you have to remember here: ASD, VSD, PDA and coarctation of aorta. All of these are gonna have pulmonary plethora except coarctation of aorta, because obviously it's just an aorta problem. So when you have pulmonary plethora, now what are the buzzwords? If you hear second heart sound wide and fixed, classic ASD, right? So you can't get this wrong. This is ASD. ASD further has 2 types. If they give you right axis deviation, this is ostium secundum defect, which is more common. Whereas if they give you left axis deviation, then it is ostium primum. Okay. So this is ASD. Pansystolic murmur, we have also studied in CVS, remember, is ventricular septal defect, and this is where you are going to see a left axis deviation. Continuous machinery infraclavicular murmur, PDA, the only continuous murmur you need to remember, patent ductus arteriosus. Whereas if they give you gooseneck deformity, now this is something we see on a ventriculography, which is almost never done, but if you hear Downs, you have your answer. So if you hear Downs, this is what is your endocardial cushion defect. If you remember anatomy, we had studied this. Endocardial cushions are what forms the valves, the atrial valve, the pulmonary valve and your mitral tricuspid valves. So essentially look at this. This is where you have this big defect, which is atrioventricular septal defect, right? So this is Downs. So we have your buzzword for each of these. And finally, if the blood flow is normal in the lungs, you give the words like brachiofemoral delay, intermittent claudication, hypertension, but in the upper limbs, right? Upper limbs, the BP is higher, but the femoral pulses are feeble. All of these are pointing towards coarctation of aorta. So this is coarctation of aorta. Usually this is postductal. Postductal is the one that presents later on, means it is just distal to the ductus arteriosus. So the upper limbs, all three vessels of the aorta get a lot of blood, but not the lower part of the descending aorta. So what is the communication? So this I have taught you. Because of this, now you are gonna have the intercostal arteries which become hypertrophied, and they are gonna take the blood from the subclavian and give it to the descending aorta. So your intercostal arteries are your major players here. Because they are carrying so much blood, what happens? They pulsate a lot. If you look at this X-ray carefully, can you appreciate how at the lower border here there is notching? So you can appreciate the notching here of the inferior rib because of the strong pulsations of the intercostal arteries which go through the lower border of the rib. So this is what we call as inferior rib notching, and this is called as the Roessler's sign. Apart from this, at the site of coactation, you can also appreciate there is this narrowing. This is called as 3 sign on X-ray. But if you do a barium swallow, it will be opposite because you're seeing from the other end. So barium swallow will be reverse 3 sign. Okay, so reverse 3 versus 3, this is coactation of aorta. Fine, so this is about acyanotic heart disease. If initially acyanotic heart disease then becomes reversed, right, then it becomes cyanotic, this is Eisenmenger syndrome. So an acyanotic heart disease patient then later develops cyanosis, think of Eisenmenger syndrome, right? Now going on to cyanotic heart disease. So this is where our approach is going to be on oligemia versus plethora. The X-rays will tell you oligemia versus plethora. If the lung fields appear blacker, means the blood flow is reduced. That's why the white markings that should have been there are not there. So consider 2 possibilities or 3 possibilities with cyanosis with oligemia. Look at this X-ray here. You can see the characteristic boot-shaped heart. So this is the boot-shaped heart, also called as core and sabot, plus oligemic lung fields. This is tetralogy of Fallot. Here you have right ventricular hypertrophy, and that is the reason for this boot. In right ventricular hypertrophy, we are gonna have this upturned apex, and that's the reason why on ECG they can give you a hint, which is right axis deviation. So what are the 4 components? One of them is right ventricular hypertrophy. The second one is overriding of aorta, and that is the reason. Do you remember in ANAT I told you spiral septum, if it is displaced, that's what's going to result in overriding of aorta. Then you have a VSD because there is a septal defect. Now this is the reason why these babies with TOF don't develop heart failure. It's because there's always a septum to equalize the pressure. If one ventricle has more pressure, it can just deload, right? It can unload the blood onto the other chamber. So that's VSD. And then the 4th component is the reason why you have oligemia. This is infundibular pulmonary stenosis. Pulmonary stenosis matlab less pulmonary blood flow, right? So that is what is oligemia. Fine. If they give you what is pentalogy of Fallot, I am sure all of you know that you also have an AST in addition to the tetrad. Apart from this, what these children can present with are cyanotic spells. Okay, so they usually ask you that what will you do first. So position is the first thing that you will change. So in a small baby, you will do knee chest position. Older baby will do squatting. In fact, you will not even need to tell. The baby has figured out on its own that if I do squatting, my cyanotic spell improves. So this essentially what it does is it will increase the afterload. So what is happening here is that now when I increase the afterload, what happens is that now more blood will go into the pulmonary artery. The cyanosis is happening because now the pulmonary blood flow is decreased drastically. If I decrease the aortic outflow, now more blood will get shunted onto the right side, more blood will leave the pulmonary artery. So that's the reason for doing this position. Apart from that, cyanosis hai, so you will give oxygen, you may also give morphine here, and you may also give beta blockers. Okay, but usually the question will be limited to this part here. Apart from this, we can do these communications, the shunting here. Essentially, the aim is to increase pulmonary blood flow. So look at the first one. This is what is done pretty commonly. This is the Blalock tossing shunt. This Blalock tossing shunt is shunting the blood from the subclavian artery to the pulmonary artery via this stent that you have put. This is a Gore-Tex graft. So this is essentially a covered stent graft that you make with Gore-Tex, or you can have two other shunts. Look at this Waterston. Waterston is between the ascending aorta and pulmonary artery, whereas Potts is with descending aorta and pulmonary artery. So you can remember PDA. Okay, so this is Potts. Fine. So this is about tetralogy of Fallot. If they give you Wolff-Parkinson-White, right bundle branch block or Himalayan P waves on the ECG, and look at this heart. This is what we call as the box-shaped heart. The most important thing here is look at the lung fields. The lung fields are oligemic because you can see the box now. You will not see it in the exam. So always make it a point to learn this correctly. The correct method is look at the lung fields first. Okay. So box shaped heart, I am sure now you know that this is Epstein's anomaly, and I know you know that it will be associated with maternal intake of lithium. It's a teratogenic effect. What happens here is atrialization of the right ventricle. So the right ventricle is become atrialized, meaning there's a huge right atrium. So that's why the Himalayan P waves, big right atrium. You can also have other abnormalities, right? Because the right ventricle is small, the pulmonary blood flow decreases, and that's why you have oligemia. On the other hand, if you have left axis deviation, means right heart is not formed only. So this is tricuspid atresia. The right heart isn't formed. That's why you have left axis deviation. So this is what you need to remember from oligemic cyanotic heart disease. From plethoric cyanotic heart disease, look at three conditions now. So if they give you large pedicle and second heart sound wide and fixed. Now, this is a secret which I am telling you. Normally people know second heart sound wide and fixed is ASD. But there are actually two diseases which show you the same finding. The other one is TAPVC. So if it's acyanotic, it's ASD. If it's cyanotic, it's TAPVC. What is TAPVC? Totally anomalous pulmonary venous communications. So now, normally you know pulmonary veins drain into left atrium. Here the pulmonary veins are like, no, I don't want to live this aam zindagi. I want to do something new. So now together they decide that we'll all go and drain into right atrium. So now there are three routes they can take. First route and the most common route is type 1, that is supracardiac. So look at what is happening. You see the pulmonary veins, they've all combined to form this vertical vein, which then drains into this brachiocephalic vein, and that opens via the SVC into RA. So they've taken this whole trip now, vertical vein, brachiocephalic vein, subclavian vein, hence opening into RA. So this is the reason for seeing your snowman, figure of 8, cottage loaf sign. Okay, so you all know the names. This is what is described as snowman, figure of 8 and cottage loaf, and I hope now you understand that this is because of the supracardiac route. So we will only see this appearance in supracardiac type. Type 2 is where they directly open into the right heart, which is the cardiac type via the coronary sinus. Type 3 is where they are very, very courageous. The pulmonary veins decide that let alone SVC, we're going to go all the way and open into IVC. Now, so much courage is also not good. Now, instead of draining into RA in this whole process, these veins get obstructed. So, that is why this has the worst prognosis. So, type 3 infracardiac, where they had to open into IVC, this is having the worst prognosis because they get obstructed. Apart from this, the other question that has been asked from TAPVC is, do you agree now all of the blood is getting mixed in the right heart? All of the vessels, SVC, IVC, pulmonary veins are opening in one chamber and they are circulating everywhere. So this is the one heart disease where you have the same oxygen saturation in all four chambers, right? So this can be answered using this point. Then look at this one here. You can see there is a small pedicle. Pedicle means this part here is narrow, and you can see this classic egg on string appearance or egg on side appearance. This is transposition of great arteries. So what happens here? From the right ventricle, you have aorta coming out, LV, you have pulmonary artery. So this is where the spiral septum does not spiral. So now you have opposite transposition of the great arteries. So do you understand now that the left ventricle, bigger chamber giving rise to PA, so more pulmonary blood flow. So that is why you can see so many bronchovascular markings. Okay, so this is TGA. Remember that this is a septum dependent heart disease, right? It needs to have some sort of a septum communication, because otherwise the oxygenated blood is going to circulate on the left side, deoxygenated on the right side, and that doesn't work. So this is where at birth itself we need to keep the ductus arteriosus patent, and that's why these babies are given alprostadil, which is PGE1, in order to keep the ductus arteriosus patent and allow mixing of this blood to happen, right? So this is about TGA. And lastly, something which is not very well known, this is what is called as a sitting duck heart, and this is where you again have a large pedicle. So sitting duck sign, you want to remember, is persistent truncus arteriosus. It means that the spiral septum never formed. So this is persistent truncus arteriosus. Both of the vessels are a single outflow channel that is described here. So this is what you need to know about heart disease. So in summary, what you need to remember: acyanotic matlab ASD, VSD, PDA or coarctation of aorta. Cyanotic with oligemia, three things: tetralogy of Fallot, Epstein's anomaly, tricuspid atresia. Cyanotic with plethora, three diseases: TAPVC, TGA, truncus arteriosus. So this is the kind of mental flowchart you need to have, and heart diseases become very, very easy. So now we talk about a few points from nutrition. This is important from a PSM and pediatric overlap. So very, very important slide here. First of all, we are looking at three images which can be tested. So the first one here is Shakir's tape, extremely important. Shakir's tape is used to measure the mid upper arm circumference, right? So we call it as MUSC, mid upper arm circumference. The importance of this parameter is that it is age independent, meaning every baby who is between 6 months to 5 years will have a constant reading here. So this becomes very useful for field workers, to analyze without having to check any sort of age or, age defined parameter. So this is age independent Shakir's tape, and you can see more than 12.5 is normal. Between 11.5 to 12.5 it's yellow, means intermediate, and what is considered to be severe is less than 11.5 centimeter. So this is what is important. It's color coded, again becomes very user friendly for the field workers. So this is Shakir's tape. What is this? This is used to estimate the length or basically the height of a baby till 2 years. This is what is infantometer. So infantometer is the baby's length till 2 years of age. After 2 years, the stadiometer, right? Beyond that, you will just stand and how you would have gotten your height checked. So that is a stadiometer beyond 2 years. What is this image right here? This is where you are measuring the skin fold thickness. This is what is called as Herpenden calipers. So Herpenden calipers, remember, this is for estimating the skin fold thickness, and they ask you at what level will you measure this. It is at the level of triceps. Okay, so at the level of triceps you will measure the skin fold thickness. Now this table, extremely important. So stunting is the term to say low height for age. When will height decrease? When you have been chronically malnourished, right? So the interpretation here is chronic malnourishment. Wasting is acute. You know how if you party too much, the next day you will say, I got wasted last night. So wasting is always acute. That's what you want to remember. This is weight for height. Extremely important. Weight for height is acute malnourishment. Whereas underweight, weight for age is both acute as well as chronic. So this is acute on chronic malnutrition, right? So if I want to define severe acute malnutrition, do you agree I will use wasting or weight for height? This is acute malnutrition. Severe is when you have -3 standard deviation. So all of these terms are when we have less than 2 standard deviation. But when it is severe, we say -3 standard deviation or lesser. So now look at the definition of severe acute malnourishment. So this is between 6 months to 5 years. Look at this, weight for height below -3, or wasting, or what did we say, mid upper arm below 11.5, or presence of edema. So now the definition of SAM shouldn't be a problem. Let's talk about the management of SAM. So this is more from the pediatric point of view, right? From PSM point of view, if you remember, we had the zones. So if it is -2 to -3 standard deviation, we were referring for home management. Less than -3, we were referring to a pediatrician for community health center. So now imagine you are the pediatrician. Now what are you going to do here? So now we have to decide whether the child can be given supervised home management or the child should be admitted. So 3 parameters we have to guess. First is there poor appetite? Is there presence of edema, or are there medical complications? If the answer to all of these is a no, we can give supervised home management. But if answer to any of it is a yes, then you got to admit the child. Let's talk about supervised home management first. So this is where nutrition is the key. So you have to make sure that the child gets enough calories. So the calories that you can start with are usually 75, but the target here is that the child should be getting 175 kilocalories per kg per day. So you start slow, but this is the target. So 175 kilocalorie per kg per day. You will give the child antibiotics, that is amoxicillin, for 5 days. All A's you want to remember: amox, vitamin A, albendazole, and vaccines. The dose of vitamin A is the same as what we have studied. Less than 1 year, 1 lakh; more than 1 year, 2 lakhs international units, right? So vitamin A, albendazole for deworming, and vaccines, whatever are the age appropriate vaccines to be given, we will ensure that the child has gotten them. So this is when you have supervised home management. But hospital management, you want to remember shielded. The things to be addressed are shielded. S for sugar. Sugar meaning these babies are prone to developing hypoglycemia. The definition of hypoglycemia, the same that we have studied, less than 45 mg per dl. This is where what is to be started is 10% dextrose. You will try if it can be given orally. If not, you can give an infusion. So this is hypoglycemia. Then what you have to remember, H for hypothermia. You got to prevent hypothermia. I for infections. These babies are prone for developing infections. So give appropriate antibiotics. EL matlab electrolyte imbalances need to be corrected. These babies particularly develop hypokalemia and hypophosphatemia. You remember Kampan, refeeding. Even if non-feeding, you will have hypokalemia, hypophosphatemia, and then you have to monitor for refeeding syndrome as well, which is hypokalemia, hypomagnesemia, hypophosphatemia, right? So both ways. E here stands for, so after electrolyte, what you want to remember? So let's revise. So we have sugar, which is S. We have hypothermia, risk of infections, electrolyte. Then you want to remember D for dehydration. So dehydration is according to our routine dehydration assessment, depending on plan A, B, C. No dehydration, some dehydration, severe dehydration. We will manage. One thing you want to remember, that here the other measures may not be reliable. So the most reliable parameter for dehydration in SAM is going to be urine output. So that's one important question. And then you want to remember E and D is going to stand for deficiencies of micronutrients. So deficiency of micronutrients are what we are going to study, that we are going to be replacing in these children, right? So this is about shielded, the mnemonic that you have to remember. For dehydration, very, very important, dehydration in SAM, you will not rely on the same parameters because consciousness here anyways might be affected, the skin pinch might be altered. So the only reliable parameter now is urine output. Otherwise in diarrhea, assessment, we don't use urine output. But here in SAM, we use urine output in children to assess their level of dehydration, right? So this is very important. Now talking about, so the immediate management is done. You've decided home versus hospital. Now let's just talk about, a bigger picture. So in any SAM nutritional rehabilitation, there are two phases. The first week is called as the stabilization phase, and second to sixth week are called as the rehabilitation phase. So in the first phase, on day 1, you are starting with around 75 kilocalories per kg per day and 0.8 to 1 gram kg per day. So these are your guidelines as to what do you have to give, and by the time you reach day 7, you have to get to 100 and 2 to 3. So you want to get to 100 kilocalories and 2 to 3 gram per kg per day per protein, and this is what is F75. This is a ready-made diet where you have 75 kilocalories, right? So this is F75 diet which can be given 2 to 3 hourly. What is important is micronutrients. So you will give all micronutrients except iron. Iron we don't give in the first week because there can be free radical mediated injury because of the same. So what do you give? You give 2 vitamins, vitamin A and vitamin K, micronutrients, copper and zinc, and you will also give folate. Alright, and then in the second week onwards, you add iron as well. Second week, now the target is F100 diet or 175 to 200 kilocalories per kg per day. So you see, we started from 70 to 80, went till 100, and eventually we want to get to where we have started home management. So 175 to 200 kilocalorie. What is important, and out of all of this, what can actually be tested is primary failure. So 2 landmark days, day 4 and day 10. So what do you check? On day 4, 2 things: failure to regain appetite and failure to lose edema. Both of these things represent primary failure, that by day 4 the child has still not regained the appetite or still has edema. Day 10, presence of edema. So any edema present till day 10. So this is important, that if the child has not started to lose edema at day 4, that's a problem. But if still edema persists at day 10, that's a problem. And failure to gain at least 5 mg per kg per day. So this is what is primary failure. So this is SAM. Going on to really primitive stuff that you already know, I believe, is kwashiorkor versus marasmus. So kwashiorkor essentially is a protein deficiency, remember. So here the serum albumin level is going to be less than 3 gram per deciliter. So here the serum albumin level is going to be less than 3 mg per dl, whereas marasmus is a total calorific deficiency where the serum albumin is not a problem. That is more than 3 mg per dl. Okay, so that's what you need to remember. So in kwashiorkor, because of the protein deficiency, these babies are going to develop a lot of edema. So look at this baby. This baby has a protuberant belly because of the ascites, the edema. So that's the hallmark. The fat is not altered. The subcutaneous fat is preserved here. In fact, if you check the skin fold, it will be more than 50th centile. In fact, it will be higher because they have edema also. Whereas these marasmic babies, look at this, their fat is completely gone. They are in the less than 5th centile. So here your buzzword is edema. In addition to that, 2 terms, 2 F things. Flaky paint dermatitis, their skin changes and they have this altered texture of the hair called as flag sign. So 2 F names. Moon phases because of the edema, enlarged fatty liver, and they are lethargic with a poor appetite. Whereas marasmus are your essentially hungry babies. You can see their loose wrinkled skin. These are called as monkey-like simian phases, and they are voracious feeders with severe muscle wasting. Okay, so this is how you have to differentiate. Next topic are genetic disorders. So we're going to be first talking about the aneuploidies. So starting with Downs. Downs is the most common aneuploidy in living babies, right? So this is what you need to remember. So Downs, most common, you want to remember. Down is trisomy 21. Patau is trisomy 13. Edward is trisomy 18. And I think you already know that. Edward is second most common. So now let's compare all of them so that you can get a ballpark figure of what are the abnormalities in each one of these. Okay. So in Down and Patau, you have hypotonia. Overall tone is reduced, whereas in Edward, the tone is increased. Okay. hands. What is the characteristic finding in Down's babies? Instead of these multiple creases, they are going to have a single crease called as simian crease. And you see clinodactyly. What is clinodactyly? It's where the little finger is smaller, right? So what happens? The middle phalange there, you don't have the phalanx. You have a tiny little piece of bone instead of the middle phalanx. So the little finger is smaller. In Patau syndrome, what you find in the hand is polydactyly, more fingers. In Edward, what you find is a clenched fist. Look at this baby here. Can you see this? They have this clenched fist with the fingers overlapping. So that's the hallmark. So clenched with overlapping fingers. Alright. As far as the feet are concerned, you know in Downs you have a sandal gap, meaning increased space between the great toe and the rest of the fingers. In Patau, the feet don't really show anything specific, but you may also get rocker bottom foot here, which is classic of Edward, right? So this is where you get rocker bottom feet, and rocker bottom feet can also be seen as an overcorrection of CTV. So you also want to remember that. This is what they look like. Have you seen these horses which rock, right? So that is how the feet look. Eyes, you know this classic eyes of Downs. You can see the mongoloid slant, epicanthal folds, and what is important is there are these spots on the iris called as brush field spots. You want to remember other iris spots we have seen in NF1. Remember Lish nodules? Those are also iris nodules. So you have brush field spots. Apart from this, remember the epicanthal folds and mongoloid slant. In Patau, the distance between the eye keeps decreasing, called as hypotelarism. Sometimes the most severe form is a cyclops, a single midline eye. In Edward, you may see microphthalmia. Okay. CVS, extremely important. Downs we did endocardial cushion defect. Everywhere else, both of these you are going to see a ventricular septal defect. So we have a VSD in both of these. Mouth, you can see the mouth is open with a protruding tongue. So that's what you are going to see here. You have a protruding tongue. In Patau syndrome, you will see that there is fusion defect. So you may have cleft lip or cleft palate. In Edward, nothing as such, but they may also have cleft lip, cleft palate plus minus. Alright, so that's what you want to remember. The other features of Downs, very, very important. This is the most common genetic cause of low IQ. GI, we have studied two things, right? So remember duodenal atresia. Apart from duodenal atresia, also remember Hirschsprung disease also has a higher chance in Down syndrome. You have atlantoaxial dislocation. This is what I have taught you in ENT. So they are predisposed to developing atlantoaxial dislocation, and that is Grizzle syndrome that was happening in the rose position. Remember on hyperextension, during tonsillectomy, adenoidectomy, these babies can develop atlantoaxial dislocation. Very important, hypothyroid. Alzheimer's, these babies have early onset Alzheimer's because it's the same chromosome 21 which carries the Alzheimer's gene, APP gene. So that's where the mutation lies. ALL is essentially the most common leukemia in these babies, but if they ask you less than 3 years, it is AML M7, which is the most common type. The main pathophysiology in 95% is maternal meiotic non-disjunction. In the remaining, you may see what is called as Robertsonian translocation. I taught you this in biochemistry where, you know, your acrocentric chromosomes. If there is a translocation, there is one baby limb and one big limb. So the baby limb gets lost and you have a trisomy. So what were the acrocentric chromosome? If you remember, 13, 14, 15, 21, 22, right? And Y chromosome. So these are the chromosomes involved in the Robertsonian translocation, and extremely important, they have conductive hearing loss because of serous otitis media. This question has been asked a lot of times. They give you SNHL in the option. SNHL is Turner's, remember that. So this is about Downs. When you go to Patau, you want to remember they have cleft-lipped, cleft palate. You can see this midline fusion where you have a single monoventricle. This is holoprosencephaly. That is something that can be associated. You want to remember Downs is linked with advanced maternal age. I am sure you already know that. So is Edward, but not Patau. Patau can also have PHPV, which is persistent hyperplastic primary vitreous, where you would be given
leukocoria, and behind the eye there is this triangular opacity with the persistent hyaloid artery. Okay, so this is the persistent hyaloid artery that is remaining here. Aplasia cutis can be there, absent ribs. In Edward, you may have abdominal wall defects and also horseshoe. So, horseshoe kidney in two places now, Turner and Edward is what you want to remember. More syndromes, can you identify this? So, tall male, there's gynecomastia which is present. This is Klinefelter syndrome. What is Klinefelter? It is XXY because of non-disjunction of X chromosome. This is associated with advanced paternal age like schizophrenia. Two things with advanced paternal: schizophrenia, Klinefelter. What about the IQ? So the IQ here is decreased, very important. Gonads, what you want to remember, they are going to have hypogonadism. So delayed puberty can be seen. Gynecomastia, very important, and whenever you have gynecomastia, remember they have higher chances of CA breast and sparse hair. You can again recognize, looking at the image, increased carrying angle, shield-like chest with widely spaced nipples, and you may sometimes have webbed neck, you may have edema of the palms. So all of these are features of Turner syndrome. And you can also remember, we had discussed this when we were discussing hypo-PTH, pseudo-hypo-PTH and pseudo-hypo-PTH, knuckle, dimple sign. This is where you only have the third metacarpal shortened. So this is where you have only one dimple. So third metacarpal shortening. This is where, remember knuckle, dimple, what we studied with Albright's hereditary osteodystrophy? Here you only have the fourth metacarpal shortened, right? So this is where only the fourth metacarpal is shortened. So that's one feature. Apart from that, in the wrist also I told you something. Remember in ortho we said maid lung deformity. So this is where you have a distal radial deformity called maid lung deformity. So this is Turner. Turner, you know, is monosomy X, but important is you always have to confirm with karyotype, because if you have a mosaic with XO and XY, in that case there is very high risk of gonadoblastoma and you must do a gonadectomy. So this is where the gonadoblastoma risk increases. Other features you want to remember: lymphedema, webbing of neck, cystic hygroma, shield chest, increased carrying angle. What about the IQ? Very important, IQ is normal here. Versus Noonan. Noonan is a phenotypic Turner, means all of these changes will be present here, but normal genotype. So this is normal XX or XY chromosome. The difference here is that there is mental retardation, meaning the IQ is reduced in Noonan. And you want to remember, in Turner, CVS anomalies are coarctation of aorta, more than that, bicuspid aortic valve, right? But in Noonan, the most common CVS anomaly is pulmonary stenosis. So you want to remember Noonan versus Turner, genotype normal in Noonan, IQ reduced in Noonan, and pulmonary stenosis. The gonads in Turner, you know, this has been asked, they are described as streak ovaries, gonadal dysgenesis, and as we discussed, there will be sensory neural hearing loss. Okay, you can also have horseshoe kidney, which is associated with this and Edward. Next, we have discussed this. So you can see this tall male, you can see scoliosis here. Look at the superotemporal ectopia lentis. What does the CT show? The CT shows you aortic dissection. So all connective tissue disorders, you know, are linked with aortic dissection. And look at this. Can you also appreciate how the chest is? This is what is called as pectus carinatum, right? So you can also see a chest wall deformity on the CT. So one CT shows you so many things, right? So this is what is Marfan syndrome. Marfan syndrome is autosomal dominant, chromosome 15, and the gene is fibrillin 1. The criteria which I have taught you in general path, Ghent criteria. Remember, we had seen the thumb coming out, the circling of the forearm. So this is what is Marfan's. Next, a few diagnoses with just looking at the images you should be able to make. So, look at the first image. They're describing epicanthal folds, large ears, full cheek, you know, so not very typical. But what they will also give you here, these are called as elfin-like faces. They will describe over friendly. These kids are over friendly. Don't confuse this with gelastic seizures. Okay, these are not laughing spells. They are just over friendly, and they will describe hypercalcemia, supravalvular AS. Remember, supravalvular aortic stenosis can also result in differential blood pressure in the two arms. What am I talking about? We are talking about Williams syndrome. So, Williams syndrome, remember, is chromosome 7 microdeletion. The next one, look at this baby here. So, there will be some hints which will be given. There is hypotonia which is associated. You have a shrill cry. That is what they will describe, and that kind of gives away the diagnosis. And the eyes, this is opposite of Downs. This is what is called as an anti-mongoloid slant. What are we talking about? This is cry do chat or cry do cat. This is where you have a shrill cry like a cat. This is chromosome 5 microdeletion. Another microdeletion is chromosome 22 microdeletion. This is Di-George syndrome. Two things you want to remember. Don't remember catch 22 even if you know it. Remember two things. Out of the entire spectrum, you have to find out. You can also see abnormal faces. That's fine. Two things you need to find out here. One is hypocalcemia and second is T cell dysfunction. This is because of third and fourth pharyngeal pouch not forming, because of which there is no thymus, no parathyroid. So that is what is very important. Next are your genomic imprinting disorders at chromosome 15. This is what we have studied in biochemistry. This is Prader-Willi. You are seeing this person with hyperphagia. That's why he's so obese. And you can see there is ghrelin increase here, growling hormone. That's why hyperphagia. So this is Prader-Willi paternal deletion, whereas maternal deletion is Angelman. So we had also told the genes, right? UB3A is Angelman, SNORP is Prader-Willi. We have already done this in biochemistry. Angelman is where you have these gelastic seizures. So look at this child now. This we have also studied when we did large for gestational age. So this is a baby who's large for gestational age. You can see that there is protruding tongue here, and you can see there is an umbilical hernia. And the characteristic feature, if this comes, I'll take a party. This is where you have two creases in the ear. This is what is Beckwith-Wiedemann syndrome. So Beckwith-Wiedemann syndrome, remember, it is associated with a risk of Wilms tumor, and this is chromosome 11, right? So this is Beckwith-Wiedemann. A few things about the skulls now. So this is a repeat question. We have discussed this in radio as well. When you see this focal lesion, which was because of a blood collection focally in the scalp, which is then later on calcified, this is cephal hematoma. So this is what is a residual cephal hematoma. The blood will then organize and leave behind this calcification. So grossly wrong spelling. So this is cephal hematoma, which is this focal calcified lesion. This is how it will look when it is acutely bleeding. Remember, it will be a localized swelling. So cephal hematoma is never generalized, it is localized, and you can see it is limited by the attachment of the scalp at the dural sites, at the suture sites. So this is where it is localized, and we saw that slowly this blood will go, and this may lead to prolonged jaundice. In contrast, remember subgaleal hematoma. Subgaleal hematoma has no limit. There is no attachment of the galea aponeurotica. The significance of that is if it bleeds now, this is going to be diffuse bleeding throughout, right? So this is going to be diffuse, and the clinical significance of the same is that now this can bleed severely to result in hypovolemic shock. So it can be so severe that it leads to hypovolemia because it's not picked early, it's diffuse, right? So it might be missed. On the other hand, another localized swelling is caput succedaneum, right? So caput succedaneum is nothing but edema. It's not blood, it's just fluid. And here you will have some sort of instrumental delivery because of which caput has formed. So this will usually resolve in 2 to 3 days, right? So these are your birth swellings. Apart from this, the next topic we're going to discuss is hydrocephalus. So hydrocephalus, look at this. This is what is called as the sun setting sign. It's because all of this dilated ventricle. What happens is when the third ventricle is dilated, just below it is the pretectal plate, right? So pretectal plate is what is regulating your vertical gaze center. So that is why the eyes droop down. So that's the reason here. The most common cause of congenital hydrocephalus, remember, is aqueductal stenosis. So this is aqueductal stenosis where the aqueduct of Sylvius is narrow, and that's why the third ventricle and lateral ventricle become enlarged. However, if they ask you acquired hydrocephalus, acquired in our country means TB, right? So TB meningitis is the most common cause for the same. You can also get this crackpot sound on percussion, and that is what is McEwen sign. We have done McEwen triangle, remember, in ENT, which is access to mastoid. We have also done McEwen sign in chronic alcoholics, where beyond a certain level they are going to have this alternating constriction and dilatation. So 3 McEwens for you. The management here, you will start diuretics first. So first line is acetazolamide, and following that you are going to now put VP shunt, ventriculoperitoneal shunt, that will take it from the ventricle and it's drained into the peritoneal cavity. Okay, this can become infected, and the best investigation is a shunt tap. Don't answer lumbar puncture. A shunt tap, it's a reservoir that's placed in the scalp. Tapping it is the best method. All right, so this is about hydrocephalus. Next we talk about craniosynostosis. So what is craniosynostosis? It is when you have premature fusion of the skull sutures. So craniosynostosis. So this is your normal skull. I'm sure you know. Anteriorly, this is your diamond shaped anterior fontanelle. This is posterior fontanelle. When does the anterior fontanelle fuse? It fuses around 1.5 to 2 years. So 18 months to 24 months, whereas posterior fontanelle fuses at 2 to 3 months, right? So what are the sutures now? So you can see here, this is the sagittal suture. These are your coronal sutures. Anteriorly is the metopic, and these are lambdoid sutures. So now you have to see which is fused and answer the name accordingly. So this is where sagittal suture is fused prematurely. So sagittal suture, this is called as scaphocephaly or dolichocephaly, SSD, sagittal, scapho or dolicho. If you see that the metopic suture is fused, a triangular shape you are seeing, this is trigonocephaly. If you see the coronal sutures bilaterally are fused. So coronal suture, this is where you will have brachycephaly, right? Short skull, brachycephaly. And if it is asymmetrical, meaning either one coronal or one lambdoid doesn't fuse, this is what is called as plagiocephaly. Plagiocephaly. Now, there are many syndromes with which craniosynostosis is associated. If I show you this, syndactyly, fused digits, you are only seeing 2 digits. What is this syndrome here? This is Apert syndrome. Okay, so this is Apert syndrome. Other syndromes which can be associated. So, if I tell you that there is maxillary hypoplasia, what is the possibility? That is associated with Cruzon syndrome. And there is the third one, which is Carpenter syndrome. All right, so this is what you want to remember. Carpenter syndrome is autosomal recessive. All right, so this is what you need to remember about these lesions. Now, a few miscellaneous points, not a few, many miscellaneous points. So, first of all, we are starting with comparison of cow's milk versus breast milk. So, what you have to remember that breast milk has lower protein as compared to cow's milk, but the amount of soluble protein is greater. Okay, so cow's milk has 3 times higher protein, but more of it is insoluble casein, whereas soluble proteins is more in breast milk. Plus, so amino acids like taurine, sulfur containing amino acids, these are higher in breast milk because that improves the cognitive development. Lactose is higher in breast milk. Calcium and phosphorus are higher in cow's milk, but the absorbable ratio is present in breast milk, right? So this is where the ratio is such that the absorption increases. Vitamin C is much greater in breast milk, but still this is not sufficient, right? So this is also something which is higher in breast milk, but vitamin C and D both are greater in breast milk compared to cow's milk. So it's very important. Cow's milk deficient in vitamin C. If we compare animals in general, so this was asked in this year's UPSC. So you can remember for everything, this is the rule. Buffalo more than goat, more than cow. So this is how the animals' milks are compared, okay? When we talk about this question, breast milk is deficient in vitamin D, vitamin K and iron. That's why we supplement it. Vitamin K, we give 1 mg. You remember vitamin K1 at birth to every babies, whereas vitamin D and iron are supplemented in a baby. You give around 400 international units per day vitamin D from birth itself, whereas iron is usually started after 6 months. Okay. Now talking about short stature, very, very important. So if they give you bone age equals chronological age, it can be one thing only, that is familial short stature. This is where bone age equals chronological age. But if the bone age is lesser, means there is scope of catching up, this is constitutional delay. But the same finding can be seen in deficiencies like hypothyroid, hypopituitarism, which indicates a deficiency of growth hormone, right? So these also have decreased bone age. So look at this graph. If this comes, I'll take a party. So the yellow is the mean height increase. Look at this one here, blue. What you can see is this child is always lagging, but in the end, they catch up and reach the mean. So this is what is the most common type, that is constitutional growth delay. Okay, so this is constitutional growth delay where the child eventually catches up. That's what you have to remember. Whereas look at the solid blue line, the child never catches up. Whereas look at this shaded, last part फिर से बोल रहा हूँ. So look at this shaded red line. This is where the child remains short because the parents are short. So this is familiar short stature, right? So this is familiar short stature, whereas if you have any pathology, now they are going to remain short. So these are your either postnatal or prenatal, which we talked about as IUGR, they are going to remain short. Essentially from this, you want to distinguish CGD versus familial. Now talking about puberty, very important. So puberty, female versus male, remember TPM. First change is thelarchy, that is breast development, followed by pubarchy, followed by menarche, right? Growth spurt happens between these two, so that is corresponding to Tanner stage 3. In males, TPM, T for testicular enlargement, followed by penile enlargement, followed by M for male, voice and hair. Okay, and in males again the growth spurt happens here, but it's a bit later. So that's why in school you would have seen that girls have puberty earlier, their height starts to increase earlier, but then males overshoot, right? So this is what are the events. What is this instrument here is Prader's orchidometer. So this is used to measure the testes volume. This is what we use for this sexual maturity rating. So this is not there in your book. I have not given it for a reason that you don't really need to memorize, but just look at this once. You may get a question asking the Tanner SMR state. So you can just Google it and see this, right? So this is the testicular volume from stage 1 to 3. You can see from less than 2.5, 3.2, 3.6, 4 and more than 4.5. Look at the description now. So you have testicular volume less than 3. You have no pubic hair and breast only papilla is elevated. So this is what is called as the prepubertal stage. Once puberty starts, the evolution is 2, 3, 4 and 5 is the adult appearance. So look at this now. So testicular volume, first there is change in texture of scrotal skin. You have pubic hair wise, you have sparse growth and you have breast bud. In stage 3, further increase with penile. So from T, now we go into P. You have darker hair and enlargement of breast and areola increases. So breast bud, breast and areola. Then you have further enlargement. So TP with development of glans, adult type hair over small area and projection of the areola and papilla happen. And now you have finally adult size and shape, medial surface, and this is important, recession of the areola to the contour of the breast, projection to papilla only, right? So this is just something that you can remember. Fine. Now moving on to extremely important, growth and development. You got this question in NEET. I'd asked for a party, no party came even though I told you this question. So here what you have to remember, look at where the peak happens. So if you see the peak growth has happened in the first 2 years, whatever brain you had to have happened in the first 2 years. So your NEET PG rank was decided at 2 years of age. So this is what is brain growth. Look at gonadal growth, it will only happen after puberty, so you can identify it. Lymphoid growth happens in the middle years, right? 2 to 8 years predominantly, and somatic growth is consistent. So that's how you identify 2 years brain, late gonadal, beach mein lymphoid, everything else is somatic. Let's compare the weight now. So let's say birth weight is X. The birth weight is doubled at 5 months, it is tripled at 1 year, then 4x, 5x, 6x, 7. Remember, 7 is the year of symmetry where it becomes 7x, and 10 year becomes 10x. Height with age, here remember at birth, let's say the height was 50 centimeter. At 3 months, it becomes 60. At 1 year, 75. So this is very important that you have 25 centimeter, meaning 50% of your height increasing in the first year. This is the maximum that the height will ever increase. At 2 years, this becomes 90 centimeter. This is important because this is approximately half of the adult height. So half of adult height is achieved at 2 years, and 4 years is where you ultimately double your birth height. Upper segment to lower segment at birth, it's pretty skewed. It's 1.8:1. At 3 years, it becomes 1.3:1, and 7 is the year of symmetry. It's 1:1. Head circumference, important. So imagine the birth head circumference. Don't imagine. It is what it is, 32 to 35 centimeter. In the first 3 months, the gain is 2 centimeter per month. Then becomes 1 centimeter per month. Then next 6 months, 0.5 centimeter per month, and next 2 years, make it half, 0.2 centimeter per month. Okay. Any month more than 2 centimeter is always abnormal. Fine. So this is about head circumference. Very important, surrogate marker of height is arm span. So arm span, you keep your hands like this from the middle finger till the other middle finger. Arm span is equivalent to height plus minus 3 centimeter. What is mid-parental height? So you take the father's height plus mother's height, take the average, plus minus 6.5. Plus 6.5 in males, minus 6.5 in females, right? Very important, short stature types now. Proportionate short stature means limbs, trunk, everything is getting shortened. This is what happens because of growth hormone deficiency. Disproportionate short stature matlab short trunk. Short trunk means any issue with the spine. That's how you want to remember. So spinoepiphyseal dysplasia, mucopolysaccharidosis, even pot spine, any spine issue, hemivertebrae. So essentially spine is an issue. Whereas short limb, very important, rickets, achondroplasia, osteogenesis imperfecta, and hypothyroidism. In achondroplasia, further you can remember it is rhizomelic shortening, meaning proximal bones are shortened more than distal. Matlab the humerus and the femur are shorter, right? So this is all about the short stature. So now let's talk about CH. CH is congenital adrenal hyperplasia. So here we are going to make it very, very easy. Just don't mess up the box. What you have to make is a table with mineralocorticoid first and then testosterone. Okay, so alphabetical order. Now write down whatever deficiency they are asking. So 21, 11, 17. Now what you have to do is whatever is a 1, increase it. Whatever is not a 1, decrease it. This is what you have to do. So what does this mean? In 21, mineralocorticoid low, meaning the baby is going to be in a shock. Testosterone high. Who will this affect? XX. So XX is going to present with ambiguous genitalia. So this is the most common cause of female pseudohermaphrodite. Most common deficiency is 21 hydroxylase. What about 11? This is increased. So now the BP is increased and so is testosterone. So this is where again you will have ambiguous genitalia, but now not in shock but raised blood pressure. 17 meaning mineralocorticoid is raised, so high BP and reduced testosterone. So this is what is going to affect XY male who's going to come to you with ambiguous genitalia, right? So this is how it becomes very, very easy. Let's talk about 21 now. The screening, you will measure the levels of 17-hydroxyprogesterone. The next step here is to first, because the baby is in shock, give the baby IV fluids and then you have to supplement them lifelong with hydrocortisone, that is going to take care of the cortisol aspect, glucocorticoid aspect, and fludrocortisone is going to take care of the mineralocorticoid aspect, right? So this is what you have to remember. Neonatal hypothyroidism can be detected on heel prick test or a dried blood spot. In fact, all of your neonatal screening is done using this. So, your tandem mass spectroscopy for PKU, do you remember? So, tandem mass for inborn errors of metabolism. CH, in fact, can be detected with antenatal screening, right? Here you have gotten a question that if a child has neonatal hypothyroidism, we will do the ultrasound and we will do the radio uptake iodine scan. So if I tell you that ultrasound is showing the thyroid but the radioactive iodine uptake scan is negative, what does that mean? It means that there is thyroid hormone dysgenesis. There is dysgenesis of the thyroid, right? Because of which it's not producing the hormones. So this is what you want to remember for thyroid dysgenesis. This is the most common cause of neonatal hypothyroidism. Next, look at this image, has been asked many times. So you can see that the bladder is outside. This is bladder extrophy. Remember, this is associated with adenocia of the bladder, vowels stick together. This is also associated with epispadias. And you want to remember on the X-ray there will be pubic diastasis, meaning the pubic symphysis is wide apart. So now just talking about recurrent UTI in children approach. So there is a slight update here that I want you to know about according to the new OP guide. When a child less than 5 years is presenting to you with recurrent UTI, the first investigation that you will do is ultrasound. Okay, so ultrasound is going to show you whether there is any evidence of cystitis or pyelonephritis or there is any structural abnormality. If ultrasound is abnormal, the next step that we want to do is rule out the most common cause of recurrent UTI in children, and that happens to be VUR, which is vesico-ureteric reflux. And we know that the investigation of choice for detecting vesico-ureteric reflux is MCU. So if ultrasound is abnormal, then we want to go for MCU to know whether VUR is present or not and see how it will appear. So this is what is an micturating cystourethrogram, and you can see how the contrast while we are doing MCU should have come down. But here you can appreciate how the contrast is going up into the ureter, into the kidneys, and this is called ballooning, and we have also studied this in radiology where I have taught you the grades of VUR. Right? So that is what you will do next. And if MCU is abnormal, meaning if MCU is showing us VUR, now I want to know whether there is any renal scarring which is associated because of VUR or not. So that scarring is detected on a nuclear medicine scan, which is a technetium scan called DMSA. So DMSA is a morphological scan and that can detect renal scarring. So that's a complication of VUR that we are trying to detect, right? So this is going to be the sequence, right? For the treatment, you can create a submucosal tunnel at the insertion of the ureter. But what is a newer treatment? So what is existing is surgery for a submucous tunnel. A newer modality is sting procedure where you will do submucous injection of Teflon, right? So this is a newer modality. Very, very important is the IMNCI model for pneumonia. So they have asked you this lot. We follow the IMNCI guidelines. Now we also have SARS guidelines for childhood pneumonia. And the only thing you want to remember is their chest indrawing comes as a severe manifestation. That's the only difference. So here pneumonia is fast breathing with or without chest indrawing with saturation more than 92. What is fast breathing? Less than 2 months 60, then 50, then 40. So you want to remember 2 months, 2 to 12 months, 12 months to 5 years. So this is pneumonia. Severe pneumonia means high risk features which include central cyanosis, not feeding, convulsion, lethargy, unconscious and severe respiratory distress, not indrawing. Okay. So here what you have to do is you will give one injection of gentamicin and you will refer the child. For pneumonia, this is where questions have come. You will keep the child on oral amoxicillin for 5 days, whereas nothing of this, nothing managed like cough and cold. Very important, what do you see? This is the Gover's sign where the baby has or the child has proximal muscle weakness which is early. So they are going to use all of their body weight to stand up. So that's Gover's sign, and this is where you see this hourglass configuration of the muscle called as pseudo hypertrophy. So we can see and we feel like, oh, the calves are very strong, he must be working out. But no, it's actually fat deposition. So that's why the muscle is gone. There is fat deposition resulting in pseudo hypertrophy of calves. What are we talking about? We are talking about DMD or BMD. So Duchenne's or Becker's muscular dystrophy, where you have a mutation of the dystrophin gene which is X-linked recessive. So this is what affects boys more commonly. Two mutations, nonsense mutation, the more severe one where the truncated protein is there, it's DMD, whereas inframe mutation where it's not truncated but the quality is affected is BMD. So DMD, BMD have the same manifestations, just that DMD progresses faster. So now let's discuss an approach to refractory rickets. We've already studied rickets in radiology as well as ortho, right? The radiological features, you'll see the metaphyseal cupping, splaying, fraying, there'll be growth plate widening. Now let's talk about an approach to rickets which is not responding to treatment. So in that case, what you have to start with, just remember this approach, right? We have to look at the phosphorus. The moment we see that the phosphorus is raised, you know that CKD is the only condition, right, where you're going to have high phosphate. You have phosphate retention because the kidneys are unable to excrete the phosphorus. So this is straight up, as soon as you see high phosphorus, you know it's because of CKD. And what happens in CKD? The 1-alpha hydroxylase enzyme, the enzyme that was supposed to make 25 hydroxy vitamin D into the active 125 hydroxy vitamin D, doesn't happen. So that explains the low calcium here or the refractory rickets here. Going on to serum phosphorus being normal, now look at the pH. If the pH is low, matlab it is acidosis, right? So metabolic acidosis with a normal anion gap, this is RTA. Commonly, the RTA that causes rickets is the proximal RTA, right? Because you have lack of absorption, you have everything going in the urine, calcium, phosphate, everything is lost in the urine. But even in type 1, you know, you may have rickets sometimes. So remember, it's proximal more than distal or type 2 more than type 1 which may have rickets. So this is about blood pH. If the pH is normal, this is where we actually go into the real deal. Look at the serum PTH. Serum PTH high. So this is where you look at vitamin D dependent rickets type 1 and type 2. In type 1 vitamin D dependent rickets, the problem is again with the same enzyme 1-alpha hydroxylase. So this is where the active vitamin D does not form, right? So this is why you have rickets which is refractory to treatment. But is this easily treated? Yes, this is easily treated if you give the active 125 form, which is the calcitriol form. This can be treated. So this is where you don't have the active 125 vitamin D, right? So this is where we can supplement this in the treatment and this can be treated. Type 2 vitamin D dependent rickets is where you have end organ resistance. Now, Can this be easily treated? No, this is where we have a problem. So end organ resistance is type 2, and this is where you have to give very high doses. You'll use the same treatment, but you will give very high doses of the same so that a little bit will respond, right? It's end organ resistance, so a little bit might respond. So both of these, that's why are called as vitamin D dependent rickets. Both of these are also associated, remember, with ectodermal dysplasias. So these patients will have teeth abnormalities, will have hair abnormalities. So that's how the presentation is. But if the serum parathormone is normal, that means very, very important. This is vitamin D resistant rickets. This is what we had studied under X-linked dominant, right? So this is your X-linked dominant. It is a mutation of P-hex gene. When you have P-hex gene mutation, remember this is the phosphaturic type of rickets. Phosphaturic matlab there is a compound which is called as FGF23. This is the one which is increased here that leads to phosphaturia. So this is what is also called as the hypophosphatemic rickets. Very, very important. So vitamin D resistant rickets, hypophosphatemic rickets, low levels of phosphate. This is something which can also be acquired, and it's a cause of TIO. What is TIO? It is tumor induced osteomalacia. So because of various mesenchymal tumors, for example hemangiomas, right, you may have this compound which is FGF23 getting released, resulting in hypophosphaturic rickets. So this is your overall approach. So in essence, I've told you the various causes of rickets. So one is nutritional deficiency, which we have tackled, right? You will give vitamin D, the patient will be okay. You will give calcium, the patient will be okay. But if the patient doesn't respond, now you have to look at all of these causes. If phosphorus high, CKD. If pH low, acidosis, renal tubular acidosis. If pH is normal, look at the parathormone. If parathormone is raised, it means that it is vitamin D dependent. Either you don't have the active form or you have end organ resistance. And finally, low phosphorus is the key. This is where you will talk about normal parathormone and low phosphorus, hypophosphatemic rickets or vitamin D resistant rickets. This is the most important for the exam, the one we have discussed the last, okay? Now, talking about Wilms tumor versus neuroblastoma, first of all on radiology, look at this CCT image and tell me whether you think this is a neuroblastoma or a Wilms tumor. This is a neuroblastoma. So, the features you have to look out for when you see there is a mass in the midline. You can see how it's encasing the vessels. You can see it's encasing the aorta. You can see some specks of calcification, and kidneys are not related. The mass is not arising from the kidney, isn't it? So, this is what a neuroblastoma looks like. So, what are the features of neuroblastoma on imaging? You will see that one, it is a midline mass. Second, it tends to encase vessels rather than invade them. Second, foci of calcification favor the diagnosis of neuroblastoma. The most common site of metastasis in neuroblastoma are bone metastasis. So, if you have metastasis near the orbit, orbital metastasis, if you remember, I told you the most common primary in a child, in ophthalmology we had discussed this, is a neuroblastoma, and that is what gives you this appearance of raccoon eyes, indicates orbital metastasis. In addition, there is a paraneoplastic syndrome associated. What is this? This is myoclonus opsoclonus, right? So, this is where you will have this rhythmic movement of the eye along with myoclonic jerks. So, this is a paraneoplastic syndrome. Skin metastasis can present as this blueberry muffin syndrome, right? So, this is what is called as a blueberry muffin. This is essentially skin metastasis. So, this is what is a cancer that can metastasize to skin, it can metastasize to orbit, bones being the most common site, but lungs are a little less common here. Talking about the prognostic factors, so these are what are poor prognostic factors. So, if you remember ALL, right? ALL prognostic factors also we had done in two similar boxes, where hypodiploid, if you are low in energy, is that good or bad? That's bad. So, you are also hypodiploid is bad. Anemic, we know anemic is associated with neuroblastoma. Amplification, poor. In addition, ALK. So, ALK we saw was associated with a lot of cancers, if you remember, adenoceal lung,
inflammatory myofibroblastic tumor. We had also talked about anaplastic large cell tumor. In addition, now you can remember neuroblastoma as well comes into this list. Loss of heterozygosity of 1 and 11 is also poor. On the other hand, what are good prognostic factors? So, this is a mutation. TRK1 is a marker of a good prognostic factor. A younger child, in contrast to ALL, a younger child here is good. Lymphoid infiltrates and soft tissue involvement is good, again unlike ALL, right? So, you have to just remember this. Now talking about Wilms tumor. So Wilms tumor is from the kidney, right? So when you look at the radiology, you will see that the epicenter is in the kidney. It is involving the kidney rather than being in the midline. So that's the first point that you will see it associated, arising from the renal origin. Then you will see that it tends to invade into vessels rather than encasing them. So it will enter into right renal vein or left renal vein and can also enter into IVC, much like RCCs. Okay, so it invades. Secondly, calcification is not very commonly seen. And the most common site of metastasis here are the lungs. Okay, so this is what you have to draw as a parallel between Wilms tumor versus neuroblastoma. The risk factor for Wilms tumor are asked. So first of all, the genetics, you have WT1 and WT2 both on chromosome 11. So WT1 and WT2 both are on chromosome 11. With WT1, there are two syndromes, Wagner and Dennis-Drash. What is Wagner? You have Wilms tumor, you have aniridia, you have growth retardation and genitourinary retardation, right? So this is what is Wagner. In Dennis-Drash, you have Wilms tumor in addition to diffuse mesangial sclerosis. So this is where you have association of diffuse mesangial sclerosis. Okay, WT2 is associated with Beckwith-Wiedemann. We have already studied Beckwith-Wiedemann syndrome. You have risk factor of Wilms tumor with a horseshoe kidney, undescended testis and hypospadias. So these are the other risk factors for Wilms tumor. With this, we now talk about developmental milestones. Now you would have traditionally learned milestones like this, 4 boxes. I'm going to teach you in a non-traditional manner like always. So what we are going to do is age wise, rather than doing it milestone wise, we are going to do it age wise. What milestones are coming? Pan category, gross, fine, social, language. Okay, I feel that way you'll remember it better. Okay, so let's see. When the baby is very small, 1 month baby, the baby is only one thing which develops, which is visual fixation. The baby can fixate at the site where they want to. For example, you will have some rattle, baby can fixate there. So that's 1 month milestone. At 2 months, the baby now starts to smile, social smile. Now, unlike the name, social smile is not that you play with baby and baby is gonna smile. Social smile is actually spontaneous smile. The baby doesn't respond with a smile. You might feel that baby is smiling at what you are doing, but it's not the case. Social smile is something random. Baby will smile when the baby wants to. Okay, so this is what is actually social smile. It's spontaneous. It's not responsive. The responsive smile comes in later on. Okay, so this is 2 months. At 3 months, I told you palmar grasp disappears because now the mother is recognized, if you remember that, right? So palmar grasp disappears, the baby can recognize mother. So now look at this mother story here. This mother is not a normal mother. This mother is a scary horror movie mother. So as soon as the baby sees this mother, the baby gets scared. And what is scared baby sound? It is coo. So you want to remember the baby starts to coo at this time. And imagine when we are scared, what do? We do like this, right? The small baby, when the baby will shake, they might have neck dislocation. So in order to prevent that, the baby ensures that by this age, the baby has learned how to do neck holding. So you will remember mother story, mother recognizes mother, scary mother, so cooing, neck holding and palmar grasp disappears. So this is 3 months. For 4 months, you want to remember 2 twos are 4. So 2 buys here. By dexterous reach, anything you give, baby will reach out with 2 hands and they'll put it in their mouth, mouthing. And they also have binocular vision. Only when I have binocular vision can I reach out for something, right? So bidextrous, binocular mouthing. 4-letter word, we don't use these terms anymore, right? Lol, rolling on the floor laughing. So this is rolling on the floor laughing, which means the baby now learns how to do rolling
And the cutest thing ever, laugh out loud. Okay, that comes at 4 months. And if you pull the baby will be pulled. There will be no head lag. Before this phase, they say, right, don't pull a baby to sit. So this is all coming at 4 months. Going on to 6-month milestone. So 6 month, you want to remember 3 ones make a tripod. Tripod meaning the baby is now sitting with support. So sit with support at 6 months. What are the 3 ones making a tripod? Mirror play, baby playing alone. Unidextrous, now baby can reach out with one hand and can transfer. And monosyllables like ba, da, baby can say at this point. Baby is having stranger anxiety at this point and listens to no. So you can remember mono, listens to no. So all of this is happening at 6 months. Going on to 9-month milestone. So do you remember in psychiatry we learned something about borderline personality disorder, toxic girlfriend. So this is where we have toxic girlfriend story. What do you want to remember? That this girl here is immature. So immature Prince Grasp. She wants a permanent relationship, but she keeps saying bye-bye. So you want to remember object permanence. What does that actually mean? It means that now even if you are not in front of the baby knows that mother exists, right? Whoever is in front of me are not the only people that exist. So baby has that whoever is not in front of me also have their presence. They're just not here. So that concept is object permanence, comes in 9 months. We have studied this under sensory motor stage of cognitive development of Piaget as well, right? So this is the first stage, which is object permanence, right? We will say bye-bye and bisyllables like mama, dada, baby will say. So going back to our girlfriend here, so immature, wants a permanent relationship, keeps saying bye-bye. She wants to be without support, but she keeps crawling back to him. So she sits without support and crawling, and all this while the baby is also clapping. Wow, entertainment. So baby is clapping at 9 months. So the clapping milestones comes at 9 months. Then you have 10 months. So if you have seen Friends, this scene speaks to you. You can hear this scene if you have seen it, right? It's like synesthesia. So this is our pivot scene. And you know Friends has 10 seasons, so 10-month milestone. So this is where they're carrying a sofa up and they have to pivot, right? So the pivoting means to diagonally shift. So you can also remember diagonal localization comes at this point. Now the baby can stand with support. So while they are carrying the sofa, are they carrying with support? Yes, they have to carry it with support. Now, no matter what anybody says, right, whether or not they were on a break, Ross did cheat on Rachel. So Ross is a creep here, and Ross and Rachel are playing peekaboo with their relationship. So that's what you want to remember, right? Creeping, peekaboo, stand with support, 10 months. Going on to 12-month milestone, this is where baby ka birthday hai. So baby has the happy birthday party. So this is where the baby now has to become very mature. Can't put everything in the mouth. So mouthing disappears. Baby is the host. So baby will come when called, stand without support, and starts to entertain people by throwing ball, casting. Casting means whatever you give this child, they'll throw it, okay? And 12 months, so 1 to 2 words baby can say, and you can see how a baby can drink water using a sipper, right? So this is 12 months. 15 months, now it's almost our mini-me, almost an adult baby. So 15 months baby can now walk alone. Baby will say whatever they want, jargon, they'll make up words, right? So this is jargon, imitate scribbling, and 2-block tower. You can imagine these are 2 blocks, so 2-block tower. Then comes 18. 18 matlab adult story. Okay, so this is adult story time. So now our baby has learned how to walk alone, right? So unfortunately, the baby ventures into the parents' room when he was not supposed to. So what's going on during that time? Domestic mimicry. Exploration of drawer, unzipping for certain reason is going on, and our baby comes inside and baby is traumatized. So now our angry baby is running and kicking ball. So remember, 18-month adult story, baby now runs and kicks ball. And now the baby declares, I am going to feed myself. You will not touch me. So baby is feeding with spoon. And why baby actually went to the room was because now the baby is dry during day. Means the baby knows that I got to pee. So they'll go to the washroom. They'll tell I have to go to pee. So dry during day. 18-month story, so 8 to 10 words. And how many people are involved in this story? 2 parents, 1 baby, 3 cubes. All right. So this is what you want to remember for 18 months. Talking about 2 years now. 2 years matlab everything 2. Before that, look at this girl, she is jumping. So 2 years, jumping comes. Now, let's just deal with stairs here itself. How a baby learns to use the stairs at 2 years, 2 steps at every, stair. So, I mean 2 feet at every steps. Then what is easier, climbing up or climbing down? Climbing up is actually easier, right? So now 1 step at a time upwards at 3 years and 1 step at a time downwards is 4 years. Okay, so that's how you remember stairs. So at 2 years, you can see 2 steps up and down. Now everything else is a 2. Baby can say 2-word sentences, name 2 objects, draw 2 lines and parallel play. Parallel play meaning, so parallel play 2 lines. Parallel play meaning you make 2 babies sit and now they'll play with their own toys. They'll not play with each other. That's called parallel play. 6 blocks. For blocks, what you have to do is just multiply the age by 3, right? So 2 3s are 6 and 3 3s are 9, like that. Baby can ask for food and drink, can name body parts, undress completely, and to undress, baby will have to open doors, so unscrew and doorknobs come here. Going on to 3 years, this is where you get maximum questions on the basis of tricycle and triangle. So remember, it is tricycle, not triangle at 3 years. See this. If you see this image, you'll not forget. Tricycle has these circles, right? Wheels. So that's what you remember. Tricycle, circle. 1 step upwards we've done. Handedness comes at this point, whether they're going to have right-handed or left-handed dominance. 1 to 2 colors baby can name, dress plus undress, and 3 years, 3 things baby can say, name, gender and age. Coming to 4 years, do you remember our Meenal from Ofthal who is hopping? So this is hopping. So this is our girl Meenal here who's hopping, black sari which catches fire, she becomes nervous. I hope you remember. If not, once you get to Ofthal, you'll know. So this is 4 years. So 1 step downwards we know. Now if you have played this game, you know that you have to do right and left according to numbers, right? So you should know how to draw square and cross. And this is almost like a bridge. And while our Meenal is hopping, she's singing a poem. And you can't play this game if you don't know how to do right-left discrimination. So this baby learns. Baby also goes to toilet alone and scissor. So toilet alone tells us that nocturnal enuresis, on a different note, right, I'm just telling you, nocturnal enuresis is abnormal beyond 5 years, right? So beyond 5 years, if a baby is wetting the bed at night, that's abnormal. The first treatment that you will do, first of all, you will ensure that there is no infection. So rule out UTI based on the symptoms. Secondly, you will use alarm. Before you start any sort of pharmacotherapy, start the alarm therapy where an alarm will ring and wake the baby up as soon as the bed is wet. Okay, so that way the baby will slowly learn. And if not, then you will go to pharmacotherapy where desmopressin is preferred. Imipramine can also be used, but desmopressin is preferred, right? So in this order you have to go if it doesn't respond. Going on to 5 years, so this is where we have skipping, and this is where triangles come in. 3-step command baby can follow, tie shoelace, ask meaning of words, 5 colors, and can make a gate with blocks, right? So this is what we need to know. So now let's just do this the conventional way, all right? So when does the neck holding come? So neck holding comes as we saw at 3 months. Rolling on the floor, 4 months. Tripod, 6 months. What you should do is pause this video right here and try to fill this yourself and then check, okay? Stand without support, sits without support is our immature girlfriend who wants to be without support but keeps crawling back to him. Standing without support is 12-month baby, right? Ross was stand with support, 10 month. Walks alone, mini-me, 15 months. Running and kicking ball, 18. Stairs now. So 2 feet step, 2 years. Tricycle, alternate upstairs, 3, alternate downstairs, hopping, 4, skipping, 5. Fine motor, bidextrous, 2 twos are 4, so 4 months. Uni was 6. Immature girlfriend, 9 months. Mature baby, 12 months. 2 blocks, matlab 15 months. 3 block, adult story, 18 months. Then multiply. So 2 threes are 6, 3 threes are 9. Cross and bridge was 4 years, triangle was 5 years, right? Next, social smile, 2 months, recognizes mother, 3, mono, inhibits to know, 6 months, bye bye was 9 months, simple ball game, 12 months, jargon, 15. Domestic mimicry actually means this, where the baby is going to copy the parents in task. This is 18 months. Food, drink, toilet, 2 years. Name, age and gender, 3 years. Cooperatively in group and toilet alone, and household task. Last, language milestone. Alert to sound is 1 month. Cooing, 3 months. Rolling on the floor laughing, 4. Mono. Bye bye, 9 months. 1 to 2, 12 months. 8 to 10, 18. Two worded, 2 year. Questions, 3. Our Meenal was singing song and poem and ask meaning, 5 years, right? So this is what you have to approach. Lastly, what you need to know is the developmental quotient. So let's say they give you a scenario and they tell you that the developmental age is 6 months, but baby's actual chronological age is 1 year. Then what is the developmental quotient? So developmental quotient is developmental age upon chronological age into 100. Anything beyond 70% is what is decreased, okay? For labeling something as global developmental delay, there must be a delay in 2 or more domains, right? So there must be a delay in 2 or more domains. What if a baby is preterm? So basically, consider the perfect age at 40 weeks, right? Anybody who is preterm, let's say anybody who is less than 37 weeks, let's say 34 weeks. All you have to do is subtract this from 40. So that gives you 6 weeks. So basically, without any formula, just remember that you give this baby a room of 6 weeks delay, right? So for example, if the milestone that was supposed to come at 6 months in this baby will come 6 weeks later, just don't call it a delay till then, right? So you give this baby a room of the age minus 40 weeks, only for preterm. You don't do this beyond 37 weeks, right? So this is what you need to know. A few tests here. So screening versus definitive. So there are these screening tests. You got to know the name: Denver, Good Enough, Trivandrum and Fatak Baroda, whereas these are your definitive tests. So just give this a read. And with this, we finish pediatrics. I've tried to do this in a lot of detail, it's a very scoring subject, I feel. So I hope you have enjoyed this, and thank you so much.